A very good afternoon to all the delegates for today's webinar organized by IMA Pune. The topic today is dermatology, and we are going to discuss dermatology problems, skin problems, which are very important in day-to-day practice. We have excellent faculty for today's program. And in the beginning, may I request our president, Dr. Deshmukh sir, to say a few words as opening comments.
Good afternoon all. I welcome you all for this webinar on dermatology, which is a specialist branch of medicine. This is second lecture of 4-lecture series, and you will get 4 credit points. Dermatologists deal with diseases of the skin, nail, and hair, along with venereal diseases. Today we have 4 eminent faculties in this field: Dr. Pradyumna Vaidya, Dr. Sunil Thorat, Dr. Dhanashiri Bhide, and Dr. Mankar. Along with them, Dr. Varsha Shinde will speak on cardiorespiratory CPR. Over to Gitanjali, madam.
Thank you, sir. May I now welcome our first speaker for today, Dr. Pradyumna Vaidya. He is a very young and dynamic dermatologist practicing at Jahangir Hospital and Dinanath Mangeshkar Hospital, Pune. He is the youngest dermatologist to receive the International Postgraduate Training Fellowship in Israel in the field of lasers and hair transplant. He is recipient of various awards at state and national level: Dr. B.S. Bhavani Award for Best Dermatosurgery Paper in Dermacon, DJ Patil Award, Dr. Jagaukar Award for Best Paper by Practicing Dermatologists. He has been invited faculty at various national and international platforms. He is author and reviewer of dermatosurgery textbook, different dermatology journals. He is the past Honorary Secretary General of the National Association of Dermatosurgeons. He is actively involved in organizing conferences and seminars. He is very active in social work through Jnana Prabodhini and other NGOs. I feel really glad because I too am from Jnana Prabodhini. Sports enthusiast as judo player, endurance sports, and trekking. Today he is going to teach us or speak regarding fungal infections and steroid abuse, which is a very, very important topic in today's practice. Over to you, Dr. Pradyumna, and welcome to IMA.
Thank you, madam, for the kind introduction. Thanks for keeping this important topic. I think in general practice, day to day, we see many skin conditions, and unfortunately, sometimes they are misdiagnosed, sometimes the treatment is not proper, and then it leads to many problems. So, if you know what diseases you are treating, then it will be very helpful for our patients and in general for your practice also. So today my topic is steroids and fungal infection. So let me share the screen. Yeah. So I will be speaking on fungal infections and steroid abuse, and purposefully I have kept this name a burning problem of the present. Because if you see in your practice, if you are seeing say 50 patients, out of that 15 to 20 patients are of fungal infections, and the problem is there is a recurrence, the patient is not responding. Once the patient stops the medicines, again the recurrence is there. So that kind of problem we are facing day to day, and a big challenge nowadays to treat fungal infections. Now why this problem is that we will also discuss, and I will tell you how to diagnose, what not to give, what to give in my lecture. Now, this is what we are routinely seeing in our day-to-day patients. Just take the. Just. Yes. So, itching in the groins, itching on the hands, itching on the legs, this kind of scaling is there. Then there are a lot of circle kind of infections which we are seeing in our day-to-day patients. Lesions on the face, some different lesions on the groin area, then other lesions at different variable parts. This kind of infections, extensive lesions on the body, on the abdomen, in the thighs, in the groin areas, this is what we are routinely seeing in our day-to-day practice. So what changes you have seen or noticed during this presentation? Initially, when you used to see the fungal infection, it was a classical fungal infection, a unilateral annular patch with scaling, or it is in the groins, or it is in the scalp. But nowadays, due to various reasons, the presentation has absolutely changed in fungal infection, and that is very important to know, to diagnose what are the changes which we are seeing in the fungal infection so as to diagnose it properly. So again, this is also a classical fungal infection. So if you see this, you can definitely diagnose a fungal infection, but if you see the previous infections, it is very difficult to diagnose. So is this a fungal infection? Yes, this is a fungal infection, but it has, the presentation is different. Now, why these presentations are different, that we will discuss gradually. Now, there is an alarming rise of dermatophytosis. Dermatophytosis is the superficial fungal infections. We will be dealing with superficial fungal infections. We will not see today any of the deep fungal or the systemic fungal infections. I will restrict my talk only to the superficial fungal infections, which are very commonly seen. Now, what changes we have seen? Extensive involvement. You have seen in the photograph, there was extensive involvement of fungal infection. It also mimics the other conditions. So most of the times it is confused with psoriasis, eczema, atopic dermatitis, leprosy. So sometimes misdiagnosis can be there. Many family members are infected. Now, it's not an individual kind of a thing. Once a family member is infected, it can infect other family members also. Now we are seeing more of Tinea capitis. Tinea capitis is the fungal infection of the scalp. So initially it was not so common, but nowadays we are seeing a lot of Tinea capitis in adults. It was only common in children, but now we are seeing in adults also. Now what major change what we have seen is we need prolonged treatment. Initially, say 7-8 years back, when a fungal infection patient used to come to us, we used to be very happy because we give the medicines for 10-15 days and the patient used to be absolutely all right, and he used to tell, wow doctor, you have given excellent treatment and I am cured with that. But nowadays it is a big problem because we need to give treatment for a long time. Once we stop the medicines, again the recurrence is there and the patients are very annoyed with the treatment. How to tackle this, we will see in the subsequent slides. So recalcitrant infection is very common nowadays in fungal infection. So why do you think that the disease has become recalcitrant or chronic? So as I have said, sometimes it is a misdiagnosis or sometimes it's the missed diagnosis, and there are a lot of therapeutic hurdles also. So that's why it has become recalcitrant. Now what is the problem? So sometimes there is a diagnostic dilemma. Why diagnostic dilemmas? Because nowadays we see in any age group. So age is no bar. So fungal infection can happen in pediatric age group. Yes, it can happen in pediatric age group, it can happen in infant, it can happen in adults, in senior citizens, in socially active, in a high society, low society, everywhere it comes. So age is no bar, social status is no bar. There is a lot of change in morphology of the diseases. What changes that we will see in the next slides? Multiple sites are involved. Initially, only immunocompromised patients who are on immunosuppressant drugs or HIV patients or other immunocompromised patients, multiple sites used to be involved. But in immunocompetent patients also now multiple sites are involved. Unusual sites. Initially, we didn't used to see much on the face, but now tinea facie is very common. And rapid spread of the disease is also very commonly seen. So these are the typical problems which we have seen for the fungal infections. So as I said, age and sex no bar. In males, in males, it is very extensively. You can see these pictures. These are extensive. We are in a dilemma whether it is really a fungal infection or something else. But as you see, all are fungal infections. Extensive involvement in multiple sites. Then initially fungal infection only in the groins used to be very itchy, but now we are seeing intense pruritus. Then there can be some eczema lesions can also be seen, crusted papules can also be seen, but the basic morphology is fungal. So this kind of varied presentations can also be seen in fungal infections. Double margins, you can see it is a concentric ring. So it is some kind of a modified tinea what we are seeing nowadays. Again, double margins you can see. This is because of the steroid abuse that we will be also seeing in some time. In a 3-month-old baby also we can see. Also note the double margin. So this patient has been not treated properly. So we need to examine the patient properly. Most of the times what happens, a patient comes to us, he says that there is itching in the groins. We consider this as a fungal infection without seeing, without examining, without stripping the patient. We just write some cream and tell them you applied for 10-15 days and we ask the patient to go. But that should not be the case. We should strip the patient properly. We should examine the patient properly. We should see all the sites. Now, what all sites we should see in a fungal infection? The groins we should see, the underarms we should see. We should also see the abdomen. We should also see the scalp. We should also see the beard area. Now, all the body parts should be examined for fungal infection, and we should not forget to examine the nails also. Because in nails also the fungal infection is very common nowadays, which is called as onychomycosis or tinea unguum. And if you are not treating that, wherever he scratches, he or she is bound to spread the infection to the other body parts also. So examination of the patient is very important in fungal infection. We should not just scribble the prescription and let the patient go. We should examine, we should counsel the patient about how to apply. A few of my slides are also there to explain how to apply the topical creams. Then family members are involved. So whenever a patient comes to us, we should not forget to ask the patient about the family members. Because if you are only going to treat one family member and if already all family members are infected, the infection is going to become a recalcitrant chronic. So we need to understand, are there any family members, are they involved? So we need to treat them also. So it is not only about individual, but we should treat the family members also. Now this kind of satellite lesions, lesions which are slightly beyond the routine infections are also very commonly seen, and we should not get confused whether it is a eczema or whether it is a psoriasis or something like that, but this is a part and parcel of the same disease of fungal infection. As I said, unusual sites are also seen. Now here you can see in the first picture, it is in the neck area, on the face it is there. Tinea facie is also there. Then a different kind of infection on the chest area also is seen in few of the slides. So at variable sites, the infection present. It's not only classical in the groins. Fungal infection is not restricted to groins, but other body surface areas can also be involved in fungal infections. So this kind of a presentation, a bad groin area can also be seen because of the steroid abuse. So in this we should not miss whether it is a fungal infection or whether it is something else. But this is definitely a steroid abused patient and it is a fungal infection which has become recalcitrant and chronic. So as I said, why the is there? Varied presentation as we have seen in the previous slide. Modified presentations. In the last slide we have seen the presentation is totally different. It is because of the previous medication. So we can misdiagnose it sometimes. So lot of differential diagnosis can also be considered in a fungal infection. So sometimes it can be misdiagnosis. And important point what I need to mention, there should not be a casual approach of the physician towards the diagnosis of fungal infection. What I have observed is there is just a scribbling of some ointment and no proper explanation, counseling, no proper things how to apply, how long to apply, what kind of medications to be taken, what other precautions to be taken is being counseled because everybody is busy in their practice. But if we have a casual approach, we can miss the diagnosis and there can be recurrence, there can be recalcitrant and the infection can become chronic. And as I explained you in the previous slide also, no proper clinical examination can also lead to misdiagnosis of a simple condition which is a fungal infection. So if you examine the patient properly, there are very less chance of missing the diagnosis. Now, what are the differential diagnoses we should consider when we are examining a patient? So atopic dermatitis. Atopic dermatitis sometimes can look similar to the fungal infection. Generally, the sites are different. Generally, the patient gives history differently. See, in a atopic patient, there is an exacerbation during winters. It can be associated with allergic rhinitis, and there can be a family history of atopy. So that's how you can differentiate. A gyrate erythema, which is again a presenting feature of sometimes urticaria, can mimic a fungal infection, and we can miss the diagnosis. But again, proper history can differentiate that. Osteotic eczema. Now, this is very important to differentiate, especially in the seniors, especially in the geriatric age group. We are seeing, especially in winters, osteotic eczema very commonly. Again, it is annular, and sometimes it can be diagnosed as fungal infection, and we treat the patient for fungal infection without any proper response. Lupus vulgaris again can mimic. But proper history and biopsy will be a clinching diagnosis for differentiating. Then eczemas can be differentiated. Seborrheic dermatitis, which is very close to fungal infection. Treatment also sometimes is similar to the fungal infection, can be misdiagnosed. Psoriasis. Now, psoriasis, or what we call as palmoplantar keratoderma or simple keratoderma, can be misdiagnosed with tinea. So we have to examine the other sides like the elbows, like the knees, the scalp, and then that's how we can differentiate. If the fungal infection is there in the nails, then it can be differentiated with, diagnosed with 20 nail dystrophy. Again, for 20 nail dystrophy, it is a sign of lichen planus. If there are other sites involved, that also we have to examine for. Again, you can see in this slides leprosy. Leprosy, again, a hypigmented patch which might look like fungal infection. Important differentiating factor is there will be no itching in Hansen's disease, and there is no scaling reaction. There will be no scaling at the patches. So we need to examine the patient properly. In the second upper photograph, again it is leprosy. We might misdiagnose it as a fungal infection of the face, that is Tinea facie. But again, if we examine properly, we can definitely know there is a hypoastasia on the face. So that's how we can differentiate. Then contact dermatitis or kumkum dermatitis can sometimes be misdiagnosed with Tinea facie, and scalp psoriasis can be misdiagnosed for tinea. What are the other therapeutic hurdles while treating fungal infections we come across? Now, the major problems, when I discuss with my GP friends, the main concern what they say, there is no response to standard recommended regimens. Why, that we will discuss gradually. There is a delayed or partial improvement. Once the patient is on treatment, he improves, but once we reduce the medicines or we stop the medicines, there is a recurrence, and that is the major concern of all of us. How to tackle that, I will explain you. Increased duration. Now, there is initially, as I said, 15-20 days was sufficient for the treatment, but now we have to give it for 2 months, 3 months. In few cases, we have to go beyond that also. So the risk of toxicity is there. The cost burden is also there. There was an interesting study which was conducted about the cost of fungal infection. It was 500 rupees, but now it is more than 2,000 per month, and we have to continue it for a long time, almost 3 to 4 months. It will go up to 6,000, 8,000 per month, and that is a big burden. But that is a big economic burden on the family members, and that also we need to consider. And again, therapeutic hurdle is the frequent recurrence. That is again the major concern. Now, why I have put this slide. Now, this is a sad situation of our India. Though technology wise, education wise, we are improving, but majority of the patients, majority of the people still go to the quacks. And quacks, they do anything, as you all know. So that is a major therapeutic hurdle, what I feel, in our patients, and this should be tackled very efficiently. Otherwise, our people is going to deteriorate. So this is a major therapeutic hurdle in treating fungal infection, I feel. Now the problem is again, as I said, self-medication. First choice by many. They just go to the counter, they ask मला groins मध्ये itching होते काहीतरी, there the pharmacist give some kind of a treatment, and there where the problem starts. The second problem is treatment after symptomatic improvement and do not complete the course, that is non-adherence. People take the medicines 5-10 days, they feel better, they stop the medicines and the recurrence is there. This is the second thing where the problem starts. The third and the most important part, which we'll be focusing more today also, easy availability of cheap, irrational, I'm saying again irrational, over the counter steroid based combinations. And that is again a big problem. IADVL, that is the Dermatology Society, is fighting against this irrational combination. We have approached the CGI to ban this irrational products. It is a difficult job, but as an association, we are trying to ban these products. Other things in recalcitrant infections are untreated affected family members, as we have discussed. That can be a source of reinfection. So we have to examine, we have to treat the family members also. Just like in scabies we used to do. Only one person we can't treat. We need to treat the whole of the family. Now, 83% of patients reported contact history with an affected family member. This was a study which was conducted, and it has been proven that poor hygiene is a other important thing for recalcitrant infection, especially in children. 81% of the patients were having poor hygiene, especially in children. Rules of fomites is a controversial thing, but few people have found that sharing of bed, linen and clothing, and more important in cases of children, it is seen. Now, this was an interesting study which was conducted. In this, men were more often the first to be affected, and the first symptom was Tinea cruris. All families reported a history of using an irritant soap and over-the-counter drugs. That is again an important observation. Washing all the family clothing together was a common factor. So this we need to counsel the patient to wash it separately. All families had a single bathroom. All the families used the same soap, towel and stool for bathing. Again, this was one of the reasons for transmitting. So 50% of patients with dermatophytosis have at least one other family member of their family infected at the same time. So we need to examine, we need to ask the history, is there any family member who is having similar complaints while a patient of fungal infection comes to us. So a fungal infection, then it can, the commonest is Tinea cruris, then it can be to the partner, then same soaps and towels are used, then it can be transmitted to the children, and this cycle continues. So we need to treat all the family members, we need to counsel about how to use the products, what not to do, and that is how we are going to reduce the reinfection in fungal infections. Now, patients don't adhere to the treatment. So factors for non-adherence: extreme age. If a patient is too young or too senior, so dependence on other for medicine application. If something is there on the back, he is not able to apply, he or she is not able to apply, then he is dependent. So sometimes he or she forgets to apply the medication. So that is one reason for non-adherence. Failure to get desired response, so they discontinue. So the doctor shopping is maximum seen in fungal infections. Most of the times people say ki we have gone to 4, 5, 6 doctors, औषध चालू केलं की बरं होतं, मग परत चालू होतं, मग so they discontinue medicines and they do doctor shopping a lot. Action of topical medicine in inaccessible areas is difficult. As I said, if it is on the back, it is very difficult to apply. Other things now what we see for non-adherence is prolonged duration. As I said, 2 to 3 months, sometimes 4 months can be required for the treatment. Cost burden. Now this is very important. We discussed this cost, the finances. 7 to 8,000 rupees per month can be the expense. All the families can afford that. So the cost burden is also quite high, and it is one of the important factors for non-adherence. ignorance about the nature of problem. People feel ki okay, औषध लावलं 5-6 दिवस ते बरं होईल. So they don't know about the seriousness and the recurrence. So we need to counsel the patient. Over the counter medicines, again, that is very important. They don't want to go to a doctor, but they are more relying on the, so that should be also not encouraged. Advice from friends, advice from relatives. तो relative सांगतो की तुम्ही GM लावा, बरं होऊन जाईल, डॉक्टरांकडे कशाला जातो. So that kind of attitude is still there. Then seniors, आजी की हे लाव, ते लाव, and that is what people follow. So these are the main reasons why there is non-adherence to the treatment. So important thing is how much time you are spending in first visit when a fungal infection patient comes to you, and what points you should explain to the patient and emphasize. So the key points in counseling are the personal hygiene, hygiene of clothes, type of clothes. Generally I say no to polyester, nylon, synthetic. Wear loose clothing, wear cotton clothing. Once you put any clothes, unless and until you are washing it, don't reuse it, especially the inner garments. The inner garment should not be too tight. Hygiene of personal care, individual use of soaps, toilet seat disinfection. These are the things we need to tell to the patients while we are counseling. Need of prolonged treatment. We should tell the patient, I'm giving you for 3 weeks. After 3 weeks, you will feel better, but don't stop the medicine till I tell you. Come after 3 weeks, depending on the improvement, I will decrease the dose of the treatment, and that is how we need to counsel the patient. Method of application. People don't know. See, ideally in a patient of tinea, we have to apply beyond the lesion also. The cream should be applied beyond the lesion also, but patients just apply a little bit in between where already a fungal infection has been cleared, and that is not going to help the patient. So method of application should also be explained to the patient. Treatment of other family members, I'm insisting all the time, so this is important. Shoes, socks. So shoes, if the patient is sweating a lot, we should tell them to keep it in sun, dry it properly. Socks, to change it too frequently. Simple means to keep body folds dry. Sometimes because of obesity, they are not able to dry the area properly, and the infection comes again and again. So what after bath, you can just blow dry with a hair dryer, or they can sit below a fan sometime, dry it properly, and then wear the clothing. Discussing clinical and mycological cure. Now this is very tricky because clinical cure, it can be achieved in say 2 weeks or 3 weeks of time, but mycological cure takes a long time. So that's why we need to ask the patient to come back again after 3 weeks, 4 weeks, whatever the treatment duration we are going to do. So explaining this is also important. So counseling points, it's a big slide. I will not go through this slide because it's a heavy slide, but whatever the points we have discussed, that has been mentioned in this slide. So you can put this kind of leaflets, printed material to the patient. Social awareness is also important in treating fungal infection, and mass education. So generally in our OPD, we put this kind of posters, or we give pamphlets where all the instructions are given. So once they go back home, they can again read it because they can't remember whatever all things we have told. So keeping this kind of pamphlets is also a good idea to counsel the patients of fungal infection. Now coming to the therapeutic part. So which oral drugs we should master? Shall we know majority of the drugs? No, it is not required. So what are the basic drugs? What side effects we should expect while we are using those drugs? And what investigations we should advise? So these are the 4 main drugs we should be aware about: Grisophulvin, Itraconazole, Terbinafine, and Fluconazole. Now what we should know about these drugs, the dosing I will tell you, but before that, Grisophulvin, the commonest side effect is headache and photosensitivity. Itraconazole, which is used left and right nowadays, it can cause deranged LFT, so we need to be aware of this. It can cause dizziness sometimes, and if a patient is having some cardiac problems, then the dosage should be adjusted. Terbinafine, there are a lot of drug interactions, or it can cause multiple drug reactions also, so we need to be aware. We have seen toxic epidermal necrolysis or Stevens-Johnson syndrome with terbinafine. So it can be lethal sometimes, so we should be aware of this. We should not be scared about this, but we should be aware it can cause sometimes. Fluconazole, yes, again it is coming back to forth because in between, people used to say keep fluconazole is not effective, but for maintenance nowadays we give fluconazole quite a bit. So what is the dosing schedule? Fluconazole, to be remembered, 250 milligram twice daily or 500 milligram once daily. Itraconazole, that is the commonest use, that is 100 milligram BD or 200 milligram OD. People give it 400 milligram, that is not required nowadays. 100 milligram BD or 200 milligram OD is sufficient. Nowadays, pharma companies have come with super bioavailable technology, that is SB, which comes in a strength of 50 milligram or 65 milligram, sometimes 110 milligram also. Efficacy wise, I don't see much advantage of that, but sometimes we can reduce the dosing schedule. That's the advantage of super bioavailable. Cost wise, they are coming down, so affordability is increasing. Terbinafine in the doses of 200 250 milligram BD or sometimes 500 milligram once daily, minimum for 3 weeks, and as I said, sometimes we need to prolong the treatment up to 3 months, 4 months also. And fluconazole 150 milligram once a week is not, we need to give it at least twice a week, alternate days, slightly for a longer time. Take home message: please don't use voriconazole, amphotericin B, IV fluconazole, caspofungin. These are antifungal, but these are infections. So please don't use this. Now many companies are promoting voriconazole, and I have seen prescriptions of voriconazole. Please don't use this, because this is meant to be for deep fungal infection, and if you use this haphazardly, the patient who are having deep fungal infection will face problems. So please don't use these medications. So what are the how to choice? So pharmacological properties, we have to look: history of prior exposure to antifungals, the site and extent of the lesion, skin area involved, that we need to assess before deciding what to use. How to prescribe in special population, that I will tell in few slides: pediatric, pregnant, lactation, geriatric population, and people with altered renal hepatic function. So this is important slide. Children below 2 years, fluconazole and grisophulvin can be used. Above 2 years, everything can be used. Pregnancy, it is category B, terbinafine. Lactation, fluconazole. If it is a polypharmacy, then terbinafine, but we need to see the drug interactions. Which is hepatosafe? None are hepatosafe, but if we give fluconazole, we need to have close monitoring of the liver functions. And renal safe is itraconazole. So children, grisophulvin and fluconazole, above 2 years, all can be used. Pregnancy, terbinafine. Lactation, fluconazole. Polypharmacy, if the patient is taking a lot of other medications, then give terbinafine. Hepatosafe, fluconazole with proper monitoring, and renal safe is itraconazole. So can we combine? Sometimes we need to combine the multiple drugs, but keep in mind the toxicity of the drugs, the economic burden, and drug interaction. So sometimes we do combine itraconazole with terbinafine, itraconazole with grisophulvin, or terbinafine with grisophulvin, but that for a short, once the desired results are achieved, the drug and then continue the other drug. So, but it should not be done it routinely. So coming to last 2-3 slides, topical preparations, what to avoid. So before telling what to use, I will tell what to avoid, because what to avoid is the major problem. So steroid modified tinea is a big menace nowadays. So we can see this kind of extensive stretch marks extend in the groin. Why this is happening? Because this kind of irrational combinations are being given. See this prescription: Betamil GM, Candid B plus terbinafine plus Sebifin powder. So what all things that person has used? This is terbinafine, this is itraconazole, then steroid orally also. So whatever is given in this prescription, so the patient is going to land in some or the other complications. So this is an absolute irrational prescription which has been given to the patient. So these are all irrational combinations which should not be used. I am writing the generic name also, trade names also, and you should remember: Candid B, Panderm, Quadriderm, Forderm, Dermi5. These are irrational combination and they should not be used. Absolutely not to use. If you are not able to diagnose, if you are not able to tell you what to write, give plain emollients. Plus, please don't write these combinations. Especially what I am seeing, Pandem, Dermi5, Quadritum, Clobid is written rampantly, and that is causing lot of problems to the patient. So please don't write this combination. If you are not able to diagnose, it's okay. Don't harm the patient. Give some moisturizing cream, give some antihistamine, and refer it to your colleague, to your senior, or to a nearby dermatologist. But don't please prescribe this combination. Why I am insisting? Because it can lead to this kind of a complication, this kind of a extensive tinea, thinning of the skin, prominence of the blood vessels, then perioral dermatitis, hypopigmentation, persistent erythema on the face, hirsutism, acne-like eruptions. So these are seen if the patient keep on applying all this irrational combination, and then it is very difficult to manage these patients. So please don't write irrational combination. One thing which you can carry home from today's lecture is don't use this combination. Use plain antifungal creams. Now, which antifungal creams? So sometimes excessive use of topical steroids can lead to Cushingoid features also. He has not received any oral medication, but that person was applying continuously the topical steroids, and this kind of a complication he had, Cushingoid. So which topical creams are good? You can remember clotrimazole, you can give sertaconazole, you can give ibuprofen, you can give amorolfine, cyclopyrox, ketoconazole cream, terbinafine cream, but don't combine it with any antibiotic cream or any steroid cream. Give plain this kind of creams like Candid cream, Ibernate cream, Ceriva cream, Pretty Fungin cream. There are so many creams plain which are available. So only follow these topical creams. Don't combine it with any other steroid creams. Last one slide. Method of application of topicals must be explained to the patient. Apply topical cream 2 cm beyond the lesion, 2 times daily, 2 weeks minimum after the lesions are cleared. So formula of 2 cm beyond the lesion, minimum 2 times daily, 2 weeks minimum after the lesions are cleared. So explain this to the patient. So he will apply the topical creams properly. Of recovery reduced. 2 centimeter away from the infected area, that is also important. 25 times it has been mentioned, but it is very difficult to do it practically. But at least ask them to rub it properly while they are applying the creams. So that is how we should try to counsel the patient, explain the patient, tell the patient how treatment needs to be taken. So that was all about the fungal infection. If it would have been an interactive session, it would have been much better, because I know there will be a lot of questions which will be there. And it is a burning topic, as I have mentioned in my first slide only. But what I feel the take home message is, examine the patient properly, strip the patient, examine all the sites, don't write any irrational combinations, give plain antifungals, oral medications as I told you in the dosage, use genuine medicines. There are so many pharma companies which have come with itraconazole, but we don't know what are genuine. So write trusted brands, so it will give good results, and counsel the patient about the hygiene, about the application of the medicines, and about continuing the medications is very important. So if you follow this in lecture, I will feel that I have been beneficial for you all. Thank you.
Thank you, Dr. Vaidya. It was an excellent presentation and you explained very well. Of course, there are quite a few questions, but I'll take 2 or 3 because of lack of time, and maybe at the end of the session we can take some more.
Yes.
There is one question, whether we should advise patients to use regular use of candid powder after bath for the skin folds. Is it advisable?
See, the thing is, I generally suggest patients to use antifungal powder. See, basic purpose, what I feel is they maintain the hygiene, they keep the area dry, and it has got some antifungal property. So after the lesions are cleared, we can ask the patient to continue the antifungal powder in the fold areas. No harm done to the patient.
Okay. I think this question you already answered by Dr. Neeta Gidwani. The question is how to differentiate between psoriasis and scaly fungal infections. Just in
Yes.
points, if you.
In psoriasis, we need to examine the other sides also, especially the elbows, the knees, and there is something called as a Auspitz sign. So if we scrape the lesion of psoriasis, there will be slightly pinpoint bleeding points which will be seen. And still, if you have a dilemma, the best is to do a KOH mount. That is the scraping of the lesion and send it to the microbiology lab. And in a classical fungal infection, we can see the fungal hyphae. So that's how we can differentiate. But clinically also, it is very much possible to differentiate by looking at the sites.
Okay. In the first trimester of pregnancy, if there is fungal infection on abdomen and neck, what antifungal we should use? This is by Dr.
In generally first trimester, we try to avoid giving oral antifungals. Topical antifungals are advisable. And as I said, terbinafine can be given, but generally avoid it in first trimester.
Okay.
In second trimester onwards, we can give. Tolat sir might correct me if I'm wrong.
Can a moisturizer or sunscreen be prescribed along with antifungal?
Yes, not an issue.
And I'll take the last question now. All different towels and napkins, that is understood. But whether those should be Turkish type or a pancha type soft ones?
See, I always suggest my all patients not to use Turkish towels. Two things. By Turkish towel, we are not able to dry it properly. It doesn't get properly dried up also. Pancha is very easy to dry, to clean also, and it is very easy to apply. So I tell all my patients to use a simple pancha that is always advisable rather than a Turkish towel.
Excellent. So a few more questions are there that we'll take at the end of
Yes.
the session.
Yes.
You stay with us.
Thank you.
It was a great
Thank you.
presentation. Thank you, Dr.
Thank you.
Vaidya.
Thank you.
Let's move to our next speaker. Welcome, Dr. Dr. Pradyumna, are you there? Hello, Dr. Pradyumna.
Yeah, I'm there, madam.
Just Dr. Deshmukh wishes to thank you and give you a small token of flowers,
Thank you.
virtual.
Thank you. Thank you. So nice of you. Thank you.
And this is a
IMA Pune for you.
IMA
Thank you.
Uparna.
Thank you.
So let me now welcome Dr. Sunil Tolat, our next speaker. He is a consultant dermatologist, graduate and postgraduate from BJ Medical College. He is also honorary professor at BJMC and Sassoon, consultant dermatologist at Jahangir Hospital and Pune Hospital, and he is practicing at Suyok Center, Gultekri. He is the gold medalist for MD, Gokhale Award, special interest in pediatric dermatology, and he has a lot of presentations at national conferences, also many research papers in national index journals. Dr. Tolat was an excellent teacher when I was also UJ in BJ, and we have attended all your lectures. I still remember those. So thank you for joining today. We would be enjoying your talk, and today he's going to speak about acne. Over to you, Dr. Tolat.
So I'm going to share my screen. Can you hear me? Hello.
We can hear you, sir.
Can you see my screen? Hello.
No, sir.
You can see my screen?
No, sir. Share it again, sir.
Kindly share it again, sir.
Now you can see?
Yes.
Just full
If you
screen.
can see, please go to the slideshow mode, sir.
Now you can see?
Yes, perfect.
So today we'll be talking about Acne Vulgaris and how to manage the patients of Acne Vulgaris on a general practitioner's basis. So let's start the lecture by seeing what are we going to discuss in today's lecture. So in today's presentation, what I'm going to deal with are some practical issues on the management of acne vulgaris, especially in a general practice. So we are going to see a bit of epidemiology, how common it is. Pathogenesis is important to understand the treatment and the drugs which we use in day-to-day practice. And then after understanding the drugs, we are going to have a little small workshop like thing where I'm going to project some live patients and give some practical tips about how to manage each of the patients. And then we are going to go in the future and see what's in the pipeline and the next few years, what we can get in the treatment of acne vulgaris. So acne vulgaris, these are some facts. The acne is very common, and even in a dermatology OPD, this 20% is too small. I think 30 to 40% of our patients have acne. It is important, and we all know that acne is a disease of adolescents only, and 18 to 25 years is the peak period, but still, especially in some women, it may persist till 40, 45 years also. Males get more severe acne than females, but girls get acne at a younger age. The distribution of acne can be mostly on the face, but even the back, chest, shoulders, and oily face and seborrhea are associated, especially in patients of acne vulgaris. So let's see why this is so. So this looks complicated, but I'll make it simple for you. Of course, the main organ in the skin from which acne arises is called as the pilosebaceous unit. This is a sort of hair follicle, and the main target of acne is the sebaceous gland. So this sebaceous gland secretes a oily, greasy kind of sweat, especially on the skin. So this is a normal pilosebaceous apparatus. Here on the face, the hair is very tiny. It may not even reach the skin, but the main part of this apparatus is the sebaceous gland. So the whole story of acne will start with the surge of androgen levels at puberty. The most important androgen is testosterone. Testosterone will stimulate the sebaceous gland, and this increased amount of sebaceous secretions will come on the surface of the skin. And on the surface of the skin, we have some bacteria, which are commensal bacteria. They are called as Cutibacterium acnes or Propionibacterium acnes. But come more of sebaceous secretion, there will be more and more of these Propionibacterium acnes, and these Propionibacterium acnes will irritate the receptors on the hair follicle. They will cause irritation of the canal of the hair follicle. They will cause an irritation over here. And because of this irritation, there will be inflammation. So remember that the first event, the starting event of acne, nowadays people think that it is inflammation. Acne is not just a disorder where there is excess sebaceous gland, but inflammation remains the primary event in acne vulgaris. Because of inflammation, there will be hyperkeratinization of the hair follicle, and because of hyperkeratinization of the opening of the hair follicle, there will be a blockage. And when the blockage is very early, you will get what is called as a blackhead. This is the sebaceous gland, more sebaceous secretions, irritation of the canal, and a blackhead. So sometimes the opening of the hair follicle will get closed and the sebaceous secretion cannot go out, and then we will get a whitehead. So these are called as comedones, which are very early lesions of acne. Many a times people only will get comedones, but depending on genetic factors or many other factors which are responsible for inflammation, it depends on how much the inflammation is, how the acne will progress. Sometimes what happens is that because of this blockage of the duct, the sebaceous secretion will break open into the skin below the epidermis, and that will cause a violent inflammation, and that will lead to the inflammatory lesions of acne, like the papules and the pustules and the nodules and the cysts. The big lesions of acne are because of inflammation. The primary event is also inflammation, and secondary inflammation will cause all the inflammatory lesions. And how much inflammation will take place in each individual depends on many other factors like the diet and other hormones and insulin growth factor, etc. But that is determined genetically also. So in acne, you have a whole lot of lesions. Non-inflammatory lesions are the blackheads and whiteheads, whereas inflammatory lesions are the pustules, the nodules, the papules, and the cysts. So once you make this differentiation, then it is easy to treat the acne. Now, acne, when treating a patient, you just got to look at it in a graded form. This is the classification of the acne lesions, which range from grade 1 to grade 4. There is no thick borderline, but there is a gray zone. And in grade 1, very mild acne, which are seen at menarche or just at the beginning of puberty, that time the nose and the T-zone will become oily. Very tiny lesions of acne will be there. And that is grade 1 acne, where there are only blackheads and whiteheads. Grade 2 acne, now there are more comedones, whole face may be full of comedones, and few pustules may also start coming. Grade 3 acne will be a combination of the comedones and the pustules and the papules, which are inflammatory lesions. Whereas grade 4 acne, which is a very severe type of acne, where you will have the big nodules, you will have lot of inflammation, and the patient may also have acne lesions on the shoulders and back also, which is called as truncal acne. So that's how the inflammation, as it goes on increases, the grade of the acne goes on increasing. So now let's see how to manage the patients of acne vulgaris. So of course, we know that the main things, just to summarize, are more of sebaceous secretions, the blockage in the follicular duct, more amount of the bacteria, which are commensal, which are Propionibacterium acnes, which cause inflammation. And of course, the driving force for all these things to happen is, of course, the hormones. And the result of all these things is severe inflammation. So in summary, we have the drugs which have to handle these primary events which happen in acne vulgaris. Like antibiotics are used to kill the Propionibacterium acnes. A drug called as benzyl peroxide kills the microorganisms, whereas it is comedolytic. Hormones might reduce the secretion. And like that, Tretinoin is one drug which might improve the keratinization and the blockage. It will open the blockage, and oral isotretinoin. So one by one, let us see the important drugs which are used in acne. In this slide, just let us concentrate that the primary events of acne need to be addressed to give the proper treatment. So this is a list of the topical medications for acne, which range from benzyl peroxide, salicylic acid, azelaic acid, retinoids, topical antibiotics, and also topical dapsone gel. So let us see in the next slide. Again, we have oral antibiotics, oral drugs also. And in the oral drugs, we can have either the oral antibiotics or we can have the hormonal agents. So let us see how to use each of these drugs in which of the patients. So let me just take you through the important points of the topically used drugs. Benzyl peroxide. This is the gold standard drug in acne, extremely useful drug, and it has got a double action. It will kill the Propionibacterium acnes, bactericidal also, and it will also be a comedolytic, and it will remove the blocked follicular canal also. So it is very effective drug. But the problem with benzyl peroxide is some people get allergic to it, and it causes excess dryness of the skin. And sometimes many people cannot tolerate benzyl peroxide. Clindamycin, again, extremely useful drug. Clindamycin has antibacterial, anti-inflammatory activity also, which is harnessed in acne. Advantage of clindamycin, it is very effective one thing, but it doesn't have any irritation potential, very few chances of contact dermatitis, and it can be used because there is no drying effect. You can use it in winter, you can use it in summer, and it is an all-round drug for acne vulgaris. At one point of time, erythromycin was also one of the topical drugs, but now because of this DPCO problem, it has been stopped it's not available only in a topical form. The next very important drug is tretinoin, what we call as retinoic acid. This is the, again, sort of silver standard drug, I would say, which has got a short and a long-term effect. Mainly, it acts as a comedolytic, and it clears the blockages in the follicles. It clears the comedones. It regularizes the keratinization, but fortunately, it has an anti-inflammatory effect also. So in acute effect is the anti-inflammatory, and the long-term effect, it will also prevent acne from coming if you use for a long time. But the downside is that at the end of 3 weeks, many patients will experience redness and scaling and what is called as retinoid dermatitis. This has to be explained to the patient. It's a little uncomfortable thing, and that's why in winter season, this is not very comfortable, at least for the patients. So it is a very effective drug for long-term cure also. The brother or cousin brother of tretinoin is adapalene. This has been made in such a way that it penetrates the comedones and it penetrates the hair follicles much more, better penetration, supposed to have a lesser irritation, And again, it has the advantage of anti-inflammatory and advantage of comedolysis and keratinization regulation. These are related to each other. Azelaic acid is a very popular drug, at least on the net and everywhere. If you see on the Google, it's a very popular drug for acne. It's supposed to reduce the pigmentation. It is comedolytic, skin lightening also. It is supposed to be very useful in theory, but my personal experience is not so good with azelaic acid. Few patients can tolerate it because of the irritation. And dapsone gel, the drug which is used for leprosy, in a gel form, is also having an anti-inflammatory effect, and especially it is used for post-acne redness, where all the acne have gone but the red face is remaining. So this is a summary of the local drugs. Nowadays what is happening is that instead of using each of the drugs locally, people prefer to use the fixed combinations of these drugs, which have several advantages. Nowadays, because of the rampant use of antibiotics, many strains of Propionibacterium acnes and many other bacteria also are starting to become resistant to the antibiotics. So that's why, to prevent the spread of bacterial resistance, we need to add something which will prevent this. And that's why you always have to combine an antibiotic with another drug. So one combination is benzyl peroxide with clindamycin. And the advantage here is that benzyl peroxide, since it is bactericidal, will prevent the spread of bacterial resistance with clindamycin. The best combination available today, and in the whole world, all the guidelines today are telling you about the combination of adapalene and benzyl peroxide. So adapalene, benzyl peroxide, it has all the advantages. Benzyl peroxide has antibacterial activity, whereas adapalene will have the comedolytic activity. Acute and chronic cases and even prevention, this is supposed to be today one of the best topical combinations. And again, a combination of tretinoin and clindamycin is available in the market. So tretinoin will also prevent the bacterial resistance with clindamycin. So the main guidelines today for topical use of creams are that the acne therapy is trying to move away from antibiotic use because of the rampant spread of antibiotic resistance. So it has been advised that do not use any antibiotic only as a monotherapy, always combined with benzyl peroxide or tretinoin. And if you have to use as monotherapy, do not use the antibiotic cream more than 4 to 6 weeks. So that is how benzyl peroxide is one of the drugs which helps you to overcome the chances of resistance with the antibiotic. So now let us see the oral antibiotics which we use for acne when the acne is too much inflammatory. So the most important group of drugs as oral antibiotics is of course the tetracycline group of drugs. So doxycycline was one of the gold standard drugs. Minocycline was found to have a more activity. Sarecycline is the best or supposed to be the newest option in this group of drugs. And of course, azithromycin and erythromycin are also oral drugs. So let me show you the advantage, disadvantages of these oral drugs. Doxycycline, still very effective in acne. It is the oldest systemic antibiotic which has been used. Problem with doxycycline is that it has a lot of esophageal gastritis. So it is a must that you tell each and every patient to swallow the doxycycline with 1 full glass of water and not to lie down after eating doxycycline. The capsule should not get stuck into the esophagus. Minocycline is more lipophilic than doxycycline. That is why more effective. It penetrates into the sebaceous secretion better than doxycycline. But it has got side effects like a CNS side effect, vestibular toxicity, and it can cause hypervitaminosis A in a very high dose. And very importantly, it can precipitate SLE. So if your patient of acne has photosensitivity, unknowingly if she has SLE, then it can precipitate SLE. As I told you, sarecycline is the best of the doxycycline class of drugs. It has got a very narrow spectrum, so chances of resistance are very low. Supposed to be safe in children, even at the age of 9 to 10 years. It doesn't stain the teeth, etc. And it is less photosensitive than the other drugs. Azithromycin, big hue and cry at one time. Many people used azithromycin, but nowadays lots of strains have become resistant to azithromycin and not very effective nowadays. Dapsone again is an effective drug for inflammatory acne and nodular cystic acne, but everyone is afraid of the dapsone syndrome and causing the allergic reactions to dapsone, which can be very severe. So it is kept as a very, very reserved drug and requires a lot of daring to use the dapsone for a small problem like acne. Now, amoxicillin is also one very useful drug, and it is useful in those patients like pregnant women or those who are contemplating pregnancy or those who have already got gastritis where you can't use doxycycline. Amoxicillin can be used, but it comes along with the package of diarrhea and sometimes might precipitate gram-negative folliculitis. So this is a summary of the local drugs. Now, in the systemic drugs, you have the ace in acne, an all-rounder drug, which is isotretinoin. Isotretinoin is supposed to be one of the it has changed the therapy of acne, and it is one of the sort of Nobel Prize winning drugs in the treatment of acne. It was approved in 1982. It is a derivative of this retinoid compound only. And the wonderful thing about isotretinoin is that it handles each and every pathogenetic pathway in acne. So it can reduce the sebaceous secretion in spite of the hormone stimulating the sebaceous gland. It can normalize the excess keratinization at the follicular wall. It can also inhibit the propionibacterium acne, and it can also reduce the inflammation. So it is the only drug which can address each and every pathogenetic pathway in acne. But the side effects are not very big, but they are to be kept in mind. The most important side effect is dry lips. The dry lips are to be handled by applying moisturizer. Dry eyes, and that's why we cannot use it before LASIK surgery and after LASIK surgery for some time. It might cause increase in triglycerides, which we got to monitor, and we have to be careful in obese patients. And very importantly, it is teratogenic, highly teratogenic. So it has to be avoided in any woman either contemplating or in any woman who is pregnant. That is there, but even contemplating pregnancy, we cannot give it. So we have to stop it about 1 to 3 months before the patient gets married, irrespective, even if the patient tells you, "Nah, marriage nantar ami planning karnar, nahi karnar pregnancy." Then you don't listen. It's very strict to avoid being pregnant when on isotretinoin, at least 1 month before and 3 months or 2 months after stopping the therapy. So this is a very busy slide which tells you the best possible treatment for each of the grades of acne. So let me take you through this slide very easily, like we can have a small workshop. So this is a grade 1 acne patient, very tiny whiteheads and blackheads, but the parents have got family history of acne and the parents bring the child to you. That's right, they are right. So we have to offer treatment for this patient, and the best treatment for this would be a standalone adapalene gel, which will act. There's no inflammation over here. So all we need is to remove the comedones and dissolve the comedones and regularize the keratinization and prevent the acne and prevent the comedones from coming back. So adapalene gel would be the ideal treatment. If the face is too oily, we can add a 2% salicylic acid face wash. And very importantly, tell the parents, mostly it is the mother who will pick at the blackheads and try to remove the blackheads. Though the child is not very aware of the thing, mother will make the blackheads to remove and will create the marks. So don't remove the blackheads manually. The doctor can remove it if necessary. And don't play around with cosmetics, and don't use all the mother's remedy or try to use everything which you see on the YouTube. So this is, conservatively, one single mono drug is enough. Now, as we progress further, now here there are many blackheads and whiteheads, and few tiny inflammatory lesions are also there. Don't be in a hurry to start antibiotics. Acne treatment is moving away from antibiotics. The best combination here would be to use a combination of tretinoin and benzyl peroxide, or adapalene and benzyl peroxide. And you can add a glycolic acid face wash because the patient is border of some pigmentation which has already occurred. And many a times these patients at this age, remember, they have got very oily face, oily scalp also. So a dandruff or pityriasis capitis always goes along with such type of acne. So worth adding a ketoconazole shampoo to the therapy. And again, same instructions are there. Manually, don't play around with the acne and use as less cosmetics as possible. This could be also a condition called as acne cosmetica. where lots of hair oil being put in the head and the whole night hair oil remaining on the scalp can also be comedogenic and cause more and more of acne on the forehead. So avoid using excess amount of oil in the scalp, wash the face frequently and use as less foundation, cosmetics, no scrubs, not even homemade scrubs are to be used. And this is now a patient where now the inflammatory element has started to set in, and that's why we need to add antibiotic. Now many inflammatory lesions are there. So with benzyl peroxide, we can add clindamycin gel. So a combination of clindamycin gel and either plain benzyl peroxide or benzyl peroxide adapalene can be applied at night and clindamycin in the daytime. Again, salicylic acid face wash could be a good option. And again, counsel the patient that once we get rid of these acute lesions, that's not the end of the story. Since you are now about 17 years old, you're going to get acne for 3 years and a bit of a long-term commitment is necessary. Now we go into the inflammatory zone. Lots of inflammatory lesions are there. And now is the time to add a systemic antibiotic. Minocycline would be the best choice. With proper instructions, you can add minocycline for about 4 to 6 weeks, a prolonged treatment, clindamycin gel in the morning and benzyl peroxide. If minocycline is causing gastric irritation or if it is not affordable, it's a bit costlier, then doxycycline would be a alternative to minocycline. And avoid the scrubbing, avoid a lot of makeup, avoid a lot of cleansing milk, avoid picking at the lesions and use as few cosmetics as possible. A little bit of moisturizer or a sunscreen in the morning can be allowed. So now here the inflammatory element is quite more and scarring is also setting in, a lot of scarring. We want to prevent this scarring at all stages because scarring is very difficult to treat. And the way to prevent scarring is to treat the acne aggressively. So I would think that along with our clindamycin and benzyl peroxide, now is the time to put this patient on isotretinoin. Grade 3 to grade 4 acne activity, signs of scarring is there. So I think put him on isotretinoin, which would rapidly reduce the inflammation, rapidly reduce the acne, and at least future scarring will be prevented. So this is the time to add isotretinoin. And isotretinoin can be given in a dose of, previously people used to believe that it is in a high dose like 1 to 2 milligrams per kg is needed. But now there is a school of thought where even low doses of isotretinoin at 0.25 or 0.5 milligrams per kg, that is about 20 milligrams per day on an average, is a sufficient dose for the treatment of acne, at least in our Indian population. So medium to low dose of isotretinoin, and along with isotretinoin, you can add an antibiotic, either doxycycline. Remember, we cannot give with isotretinoin because both these drugs are responsible for pseudotumor cerebri. So either you add azithromycin or you can give a short course of amoxicillin also. So get the patient out of the acute stage and then add a tretinoin agent like retinoic acid to prevent scarring and to prevent new lesions from coming. And this is a very worst case of acne where a short steroid course may be needed for the massive inflammation. Remember, right from the beginning to the end, acne nowadays is an inflammatory disease. So isotretinoin is a must. Add an antibiotic which has to be given because of lot of inflammation and pussy pimples. Dapsone gel here could be a good option because Dapsone gel is supposed to have a good anti-inflammatory activity. And nadifloxacin is one more kid on the block for acne treatment. Advantage is that the resistant strains are few because it's not very commonly used, and nadifloxacin is not irritating as tretinoin or adapalene or other acne agents or benzyl peroxide. So nadifloxacin can be a choice if the patient already has used clindamycin for a long time. So again, long-term commitment is counseled to this patient. Now, quickly, let us see one subset of acne, which nowadays is becoming very common, which is called as hormonal acne, a type of acne which is seen in adult women. The classic features of this acne are usually they are present on the jawline. They are much more inflammatory, very bothersome to the patient because she has already crossed the acne age and she is psychologically disturbed and embarrassed also. So what is the cause of this? Exact cause nobody knows, but could be something to do with the hormones and how the androgens will be responding with the glands. And there can be two types. Some women who have got acne prone skin, they can live with their acne right from the age of 18. It doesn't go away, remissions, exacerbations, and keeps on coming, which is called as persistent adult acne. Or some or the other, sometimes the patient may get rid of the acne at the age of 19, 20, and again the acne may start coming at 30, 35. That is a late onset adult acne. So the main reasons at this age could be, always take a history for OC pills. Many OC pills with progesterones can cause this. Look for other signs of hyperandrogenism like hirsutism, etc. PCOD might be one more important reason. But stress, obesity, insulin resistance, high glycemic diet may also be some other reasons for adult onset acne. The treatment doesn't differ much from our routine acne. Isotretinoin can be added if the lady has gone out or finished her childbearing and she has already done tubal ligation. Antibiotic therapy is also there, benzyl peroxide also there. But sometimes if routine treatment is not working, then an option of hormonal therapy can be offered to these patients in the form of some special types of OC pills, which contain, of course, each and every OC pill will have an estrogen component, but take care to see that the progesterone component is not androgenic. You need a progesterone component which will be a sort of non-androgenic progesterone, and OC pills with drospirenone or cyproterone acetate would be the OC pills of choice in this patient. But you have to tell the patient OC pills are not going to work like magic. It's a long-term therapy, and most of the times 3 or 4 cycles, 3 or 4 months are needed to see a good response, and a long-term OC pill commitment has to be there. So it's not easy to use a OC pill in general practice. We have to do a lot of counseling, and it is a long-term treatment. Other anti-androgen drugs like spironolactone is there, but it is not in the premise of general practitioner because dizziness, hypotension and all may take place, and it is not very comfortable drug to use in general practice in a busy OPD. So sometimes just to remove the inflammation and to suppress the androgens, a nighttime dose of a steroid is also given, but this also needs a lot of counseling and proper understanding by the patient. So this is one other special type of acne, which, as Dr. Vaidya said, becoming very common nowadays because of the use of steroids. So patients in acne, they are using steroids as a fairness cream, unfortunately. And again, very unfortunately, the steroid cream will act like magic in the first few days, and then it will start causing the damage. So first, the patient is very happy with the steroid cream and she keeps on applying it. And here you see the signs of steroid toxicity, or what is called as TSDF, topical steroid damaged face. Lots of acne lesions and hirsutism, skin has become thinner. And if you notice, the special feature of this acne is that each and every lesion is of the same stage. All are pustular papular. You won't get a mixture of comedons and all monomorphic acne with hirsutism and other signs of steroid toxicity are seen on the face. Again, difficult to treat because as soon as you make the patient stop the steroid, all the acne are going to double, and it's a very big job to bring the patient off the steroid. So help her with moisturizers and antibiotic cream, and sometimes systemic antibiotic may also be required to control these acne. So this is again a very common thing to happen, especially in girls. In boys, not very common, which are college going girls facing some problems psychologically, not getting married, family problems like that. These are, girls who can blame their face for anything wrong that happens in their lives, and they fall into a habit of picking at their lesions. And many of these girls unfortunately have a psychiatric problem like a body dysmorphic disorder, or they are in depression, anxiety, or they have got an obsessive compulsive disorder at picking of the acne lesions, and they are creating the marks and post-inflammatory hyperpigmentation. And if you tell them face on ki are don't pick at the lesions, they will always deny. Nahi, mi phodotas nahi, kute mi kai hatas lawat nahi. So it is a very big job to counsel them. Give proper treatment, treat the acne vigorously, don't let new acne comes. That usually is our job, to help the patient break the habit and get out of this condition, which is called as acne excoriation of the acne lesions, which is a psychotic neurotic disorder. So this is how the patient will stand in front of the mirror and try to pick at the lesions. Now this is a very severe form of acne, not very common, acne conglobata. This is extremely severe. Each and every lesion of acne has got inflamed, There are no comedons or not. Directly, there are cysts and inflammatory lesions and crusts, and even draining sinuses and sinus tracts are there. Pustules, nodules, abscesses are there. Bleeding sinus tracts are there. Very difficult to treat. And long-standing acne is there. And all of a sudden, the acne conglobata may set in. So when you come across this patient, not in females, but in males, many of these patients have other manifestations like hidradenitis suppurativa or pilonidal sinus, which you always have to look for when you are dealing with this acne conglobata. Treatment is difficult. Lots of high dose of antibiotics is required. Bring down the inflammation, start isotretinoin. Dapsone may also help. And a steroid, a nighttime dose may also help. Morning steroids can be given to reduce the inflammation. It's a fine balance between tackling the inflammation and the infection part of the acne. So it requires regular commitment and regular follow-up. A little difficult. Cold water compresses, NSAIDs can also be used to decrease the inflammation. So truncal acne again is nowadays a very common presentation. Most of the patients of truncal acne we see, as they come to a dermatologist, they are referred from somewhere and they are drug induced. Today, the common drugs which can cause truncal acne are, of course, systemic steroids, which are given for some medical problem. Then INH-induced acne is one of the commonest causes of truncal acne, patients who are on AKT or antituberculous drugs. And this is not worth remembering that nowadays many boys are taking these bodybuilding supplements, muscle makers and whatnot. And though not listed on the list, many of these supplements are having sort of steroids which are mixed in it without being there on the label. Or many of these body supplements have got a high caloric and high glycemic type of high carbohydrate and muscle building proteins, which might induce a flare up of the acne by stimulating the insulin-like growth factor, and that is also acnogenic. So again, today, nowadays, many patients are coming with acne lesions in older patients. Unfortunately, these patients are suffering from cancer, and in anti-cancer chemotherapy, the TTK inhibitors are, or the EGFR inhibitors, like TTK inhibitors are supposed to be one of the most important drugs which can cause a acneiform eruption. So these TTK inhibitors can inhibit the EGFR receptors and cause acneiform eruption. The paradox here is that when the oncologist sees the acneiform eruption, he is very happy, because when the acneiform eruption comes, the prognosis of the chemotherapeutic agent is very good, and it is a sign that the primary cancer is resolving. But it is a very difficult condition to treat, the drugs which cause this TTK inhibitor induced acne. So this is again surprising that even newborns and even infants, not children to TK, but newborns and infants can cause acne, can come with acne. And in newborns, the acne is because of the maternal hormones, which stimulate the sebaceous glands, which are hypertrophic because of the maternal hormones. This will wear away. But suppose if the acne remains, the maternal hormones and hypertrophic adrenals in the newborns are responsible for neonatal acne. But if these acne lesions do not go away, persist till infancy and childhood also, then it is the time to wake up and the red flag is ringing. And then you have to investigate the patient, send him to an endocrinologist and see if he has an endocrine problem or adrenal tumor or some steroid enzyme deficiency, which might lead to a virilizing syndrome later on. So it is an endocrinologist's job. So again, when dealing with acne, always examine the patient nicely and see whether there are any other signs of virilization. PCOD is one very common cause. So PCOD, along with hirsutism, along with the black neck or acanthosis nigricans and a metabolic syndrome, are the signs of androgen excess. Here you got to take the help of an endocrinologist. Some hormone tests may also be required, and concomitant treatment for the hormones may be needed to bring the patient out of these acne which are due to androgen excess. So here endocrinologist help is needed, and rare syndromes like Herin syndrome, Sappho syndrome, they have got an endocrine problem, which is a super specialist job to handle. So what are some procedures which are done for acne by, maybe you can do it in general practice or even we do day to day, is many a times the big nodules of acne will not resolve with acne treatment, and intralesional steroids have to be given in acne, and comedone extraction. This makes the patient very happy that the blackheads have been removed. He will not pick at it. How helpful it is, God knows, but just removing a few comedones in front of the patient will make the patient quite happy and stop him from picking. So this is a set of comedone extraction. So always just, to please the patient, always remove a few blackheads if they are there. Don't force them open if they are not coming out, let it be. But this is one of the simple OPD procedures which can be done in acne. Treat it occurs in about 95% of the patients. It is due to metalloproteinases. Genetic tendency to develop scars is also there. Sometimes acne may be very small and tiny, but the scars may be major. It's not always that severe acne will correlate with the scars, but many times yes. And often the scars worsen over time instead of getting better, and very challenging. So many modalities have been tried. The fact that so many modalities are there means that it is not easy to treat the scars. The gold standard modality, each of these scars is tethered in the dermis by fibrous tissue. So this is a procedure called as subcision, where a needle or a trocar is put in the skin, and the scars or the fibrous bands which are holding the scar down are broken open and the scars are released. Other treatments like combinations can also be done. Chemical peeling is there. Then you have a ablative laser like a carbon dioxide laser whose downtime is quite more. And to lighten the scars, Nd:YAG laser can also be done, something called as a Hollywood peel. And nowadays, the latest fashion is a PRP treatment, or platelet-rich plasma. You centrifuge the blood, remove the layer of the platelet, take it in a syringe and inject it below the scars. It is not FDA approved. It does work, doesn't work, God knows, but it is one of the treatments which is a fashionable treatment today. And even this PRP can be smeared on the skin, and a roller treatment, what is called as micro needling, can be done. So substitutions, chemical peeling, combination of lasers, PRP injections, so many things can be done for the scars according to how deep and how old the scars are there. So let's see quickly something new. What is in the pipeline for acne? As I told you, the main aim nowadays going ahead is go away from antibiotics. Don't use antibiotics. So the latest drug which is there in the market even now is what is called as clascosterone. So this is an anti-androgenic drug. These are the new drugs which are there. So let me just show you quickly the new drugs. Clascosterone is a new drug available in the market, not in India, but abroad. It is an anti-androgenic drug which acts by inhibiting the receptors of the DHT. As you know, the hormones are converted into active form on the sebaceous gland. So this conversion is stopped. So this is quite effective, and a lot of phase 3 clinical trials have been done. Sarecycline, I have already told you, narrow spectrum, less chance of antibiotic resistance, can be used in children, less acidity, and of all the tetracycline group of drugs, this should be the drug of choice. Then trifarotene is a derivative of a retinoid. It is a higher or advanced form of adapalene, and it is supposed to be one of the very effective drugs in acne. Albeit today it costs a bomb, not available in India, but even in foreign countries, it costs thousands of rupees. So still not a feasible option, but very soon it might hit the market for acne therapy. And surprisingly, yes, I'm just getting over. So these PPR modulators are there. And Siluton is one which can modulate the inflammatory response. And this is one, again, anti-androgen. And with that, I thank you for your attention. Thank you.
Yeah. Thank you, Dr. Tolat, for an excellent talk. A few questions are there, but I think you have answered almost every question in your talk.
Yes.
So I would request Dr. Deshmukh, sir, to felicitate Dr. Tolat. So, sorry. Dr. Tolat, please accept.
So this is okay for you?
Yes. Thank you. Thank you.
And this is IMA Pune for you.
Thank you. Thank you very much. Thank you.
Let's now go to our next speaker, my dear friend, Dr. Dhanashiri Bhide. She is MD DNB and consultant at KEM Hospital and Dinanath Mangeshkar Hospital. She is recipient of BB Gokhale Award for first in Pune University for MD exam. She has authored 6 chapters and 7 publications. Areas of interest are indoor dermatology, clinical dermatology, and lasers. She's a scientific committee chairperson for Dermacon 2020 Pune, president Pune chapter of IADVL, Maharashtra State Branch, and member of SIG Female Genital Dermatosis. She'll be speaking on vitiligo. Dhanashiri, I take slight freedom from my side, being your friend. This is Gitanjali.
Yes, I will be short and precise, and I will not go into too much of details. I will help you to make up the time. Don't worry.
Thanks a lot.
Yeah. So thank you so much, Gitanjali. And at the outset, let me just share my screen. So at the outset, I would like to thank Deshmukh sir and entire organizing team for giving me this opportunity to present my views on this topic, that is vitiligo. Is it visible, Gitanjali?
Yes, yes. You just go to slideshow mode. Yes, perfect.
I am on slideshow. Is it okay now?
Yes,
Yes. So in the next half an hour, I'll try to make it 20 minutes, and I will try to cover most of the practical aspects of this problem, that is vitiligo. According to me, it is a very complex problem because not only the patients but the families are affected. And secondly, as a treating physician, there are a lot of challenges. So if you look at vitiligo from patient's point of view, it has a lot of aspects to it. So it's a social stigma, and everybody is really worried about when the diagnosis is disclosed. Then cosmetic disfigurement, if the lesions are present on face, then it is really difficult for the patient to move out in the society. As a result, there is a lot of frustration. These patients start isolating themselves. They start feeling hopeless, and it has a severe psychological impact. At the time of marriage and while going for job interviews, there can be a problem. And because there is no pigment to protect you from the sunlight, photosensitivity again is a big problem, which makes the skin look patchy, and that adds to the frustration of these patients. So this is the patient's perspective. As a treating physician, what are the challenges? First and most important is when you see the diagnosis is not difficult, patient also knows it, but how to disclose this to the patient and to the relatives is a challenge. Then the treatment that is available as on today, it has a lot of limitations, and none of the treatments so far can so-called give you cure from this particular problem. A cost-effective treatment plan is again extremely important because it's going to be a long-term treatment, and a patient has to adhere to your treatment plan, and they will do that if it is cost effective. Then safe choice of the medicines, especially in the pediatric age group, pregnant women, essential to choose a drug which is not going to be too toxic to these patients. Long-term safety of immunosuppressives is a challenge, and differentiating other hypopigmented conditions from vitiligo in your busy practice in the clinic, especially at a general practitioner level, you have to learn how to do it so that you can satisfy your patient and you can exclude many other conditions and before giving this diagnosis of vitiligo. And of course, you have to support this patient psychologically to help them to lead a good quality of life. And I feel this is extremely important when we are dealing with this vitiligo patients. Now, what is the scenario in the OPD? You have so many conditions which look white and they look as if they are vitiligo. And when any of these conditions are seen, the patients and the families run to your clinic, and only question they have in their mind is that, is my child is suffering from vitiligo? Am I having vitiligo? So what can you do to identify one from the other? So the important steps are, first and one important thing that you have to know is whether the lesions are present since birth or whether they are acquired. So if they are present since birth, then most likely you are dealing with some kind of nevoid conditions which look like vitiligo. Look at the margins. Thorough clinical examination is important. There is something called as a Wood's light, which is not a very costly instrument to have, and you can see these lesions under the Wood's lamp. And a simple glass slide will help you to differentiate the nevoid conditions from vitiligo. So what are the points in favor of vitiligo? First and important is it is acquired. Secondly, if you look at the margins, they have a kind of a scalloped appearance. And what we mean by the scalloped appearance, I will just come to it in the next slide. The lesion is completely depigmented. That means there is no pigment at all. They look like chalk white in color. If you look at the hair, some of the patches would show loss of color in the hair, which is called as leukotrichia. And you will see that there are patches where there will be tiny hyperpigmented spots, which is called as a perifollicular pigmentation, which again is a very peculiar sign in patients who of vitiligo. And if you do look at these patches under Wood's lamp, they will be more white. So this is what it is. You can see that this patient has a complete loss of pigmentation. The second photograph will show you that there is a hypopigmented patch with hair on the surface which are white. Then this is a Wood's light accentuation of the pigment. And on the right hand side top, you can see a scallop, which is a shell. And you can see that the margins are like a wave. So it is a kind of a wave-like margin which you will see if you are dealing with a patch of vitiligo. So this scalloping of the margins is something which you should look for. And few patients will give you 3 different colors. So there is a depigmented lesion, there is a normal skin, and between the normal and a depigmented area, you will have a light brown color. And this is again a very peculiar thing that can happen, that can be seen in patients of vitiligo. This is called as a trichrome vitiligo. If you are dealing with birthmarks, obviously they are present since birth. And if you look at the margins, you can see this photograph that these margins have kind of a feathery or serrated appearance. And these are indented feathery margins, which is peculiar of nevoid conditions. And there are 2 nevoid conditions. One is nevus animicus and second is nevus depigmentosus. And you might have faced this problem in your OPD. Parents, they rush to the clinic. They want to know whether this is a birthmark or whether this is vitiligo. And a simple thing, a glass slide, can help you whether this is pigmentosus or whether it is nevus animicus. And if you see that the color of these lesions is never chalk white or milky white, there is some pigments, they are brownish in color. And if you press a glass slide on the surface, this lesion is not disappearing. And that means we are dealing with a condition called as nevus depigmentosus. It has nothing to do with vitiligo. Now, once you establish the diagnosis by ruling out all these common conditions, the second important step is to disclose the diagnosis. Now, this is extremely challenging. So when you're doing this, don't be blunt with your patient. Be sympathetic. You involve the family members, because if the family members are cheerful, they are going to help the patient to be cheerful and lead a normal life. Then there will be educational material that can be available in the clinic. You have or maybe a brochure which can deal with the common questions and the do and don't that you can advise to your patient. So that is another thing that is usually helpful. There are different support groups, and especially important at the time of marriage, because there this problem can be a hindrance to get a girl married or to get somebody married in a family where there is vitiligo. So take help of the support groups. We do have a support group in Pune, which is run by none other than Dr. Maya Turkule. She was a past president of IMA, and she also has a marriage bureau, a special marriage bureau for these people. So you can definitely guide your patients to take the help from this support groups. The hereditary factors, they are overemphasized. Like there is a single case in the family, only single patch, and people are worried whether this person is going to transmit it to other family members, or whether it will be seen in the children and all. But mind well that only 20 to 25% of the patients it is hereditary. All other patients you cannot really identify the cause. So hereditary is not to be overemphasized when you are discussing this problem with your patient, and also explain that you will be able to help the patient to control the problem. You cannot cure it. And if there are centers or doctors who are claiming cure, they are lying to you. And don't visit these places and spend lot of money, because this is not possible. So as I was telling you, hereditary is only in less than 20%. Then chemicals, like if a person is wearing a plastic footwear, especially in the rainy season, that material is not suitable. Then bindi, if the bindi has a kind of a gum underneath, that is not suitable. Hair dye, these are some things which these patients can avoid. And sometimes these are the culprits, and it is a chemical induced leukoderma rather than the autoimmune type of disease that we are seeing, and these patients are comparatively easier to manage. Another place where you will see is on the breast of a woman. There are their money purse inside their blouse, and that the leather or the material that is present in that money purse, that can be a culprit for the leukoderma. So try and identify these kind of triggers which will help you to differentiate these from the traditional autoimmune type of patients. Another myth in the minds of patients is that, can I eat sour things? If they go to Ayurvedic person, they are going to stop so many things. They are going to stop white color things. But remember that citrus things and vitiligo, there is no relation. So they can continue to have normal food as you and me. Then other autoimmune conditions, should we do a workup for these patients? So one thing that you can always screen is thyroid dysfunction, because that is something that is not very difficult to identify. And if identified, you can provide treatment for it. Systemic complications like diabetes are not seen in these vitiligo patients. So you always explain to them that if you have diabetes, it is not seen, but it is killing you from within. Your heart is at risk, your kidneys are at risk, your eyes are at risk. But if you have a vitiligo, it's just a cosmetic problem. It is just affecting your appearance. But fortunately, you are going to be much more healthier than a person who is having diabetes. So if you explain it like this to the patient, they understand it better. And then, of course, not to visit the quacks, not to fall prey to the advertisement. And best thing is to get clarified, is to visit a dermatologist and make sure that you have it or not. So our Pune chapter, we have these kind of brochures in English and Marathi, which we also hand to the patient, so that at home they go home and can read it easily. It's very self-explanatory. And as a support group, have a magazine, they have this Vadhuvar mother also for these patients. They do have activities like marathon races, which increase the awareness. And we Pune chapter also had one activity in IMA with these people. So such kind of activities definitely help clear the myths about this particular problem. Now, next important part is the treatment planning. And again, I will say that cost-effective treatment is what has to be planned for your patient, so that will stick to your treatment plan. So you have a pharmacological treatment, which can be a medical treatment, either topical or systemic. And you also have a surgical treatment option available for limited patients. And those who have a generalized disease, when the pigment is uneven and it doesn't look good, then you can also provide them option of total depigmentation. So it's a holistic approach, and everything goes with a psychological support all the time. Every time there is a follow-up, you have to console your patient, talk nicely, make the patient comfortable, and so that they will be very happy. Now, the treatment goals, when we are treating, as I've said, there is no cure. What we want to do is achieve stability. So if your patient is having lesions coming one after the other, try to achieve stability. Secondly, the culprit cell or the culprit thing is a melanocyte, the pigment in the melanocyte. And this melanocyte in vitiligo patients is a weak melanocyte. So it is prone to damage. And it is prone to damage because of the oxidative stress. So you will provide medicines which will decrease the oxidative stress on the melanocyte. Then you want to select an option which will help to improve the melanocyte migration to the vitiligo patch. So your patch is there and the surrounding skin has pigment. So you want to use something which will push this pigment from the surrounding skin, or you want to use something which will enhance the pigment around the hair follicles. So this is another step that we can take by choosing a correct molecule. Then sometimes you give medical treatment, it is not helping, it fails. And then you can replenish the lost melanocyte reservoir by taking help of surgical options. So you can take skin from somewhere else and transplant it at the site of vitiligo patch and give a medicine which will the proliferation of these newly transplanted melanocytes. And of course, identification of trigger factors that we have discussed is extremely important. So the pathogenesis is polygenic multifactorial, and melanocyte destruction is the key event, and etiology can vary from person to person. So the autoimmune hypothesis, the neural mechanisms, then combination of one or two different mechanisms in a particular individual, antioxidant deficiency, a weak melanocyte, and apoptosis of melanocyte are some of the hypotheses that are proposed in the etiopathogenesis of vitiligo. Now, it is essential to understand the limitations of the current available options, and you have to target the different therapeutic arms or different pathogenic arms in the etiopathogenesis. So you may not just concentrate on autoimmunity, but you can use a molecule or a drug which can act on autoimmunity, which can also reduce the oxidative stress, and a combination can give a better outcome in your patients. Now, remember that once you've chalked out a treatment plan, the patient is going to ask you, when I'm going to get better? But you have to tell and explain that the response is unpredictable. Let us try the current modality for 2 to 3 months and see whether you are responding or not. And I will try and help you to maintain this achieved response by giving you a maintenance therapy. Phototherapy is one option, which is actually a mainstay of our treatment. But the challenge is that the facility is not available in many places. And those who are a working class of people, it is for the patient, they have to visit the phototherapy unit to take this facility, but that is not possible. So there are limitations for this phototherapy option. So the treatment would depend upon whether the patient is having spreading disease. Secondly, whether the disease is limited only to a particular segment or the patches are in multiple places, whether it is a localized or a generalized disease. Then if the lesions are on the exposed part, you have to also help them to camouflage, because it is difficult for a person to go out to work with a big patch of vitiligo on the face. And hairy area and a non-hairy area, the response is different. If there are associated comorbidities, you have to tackle them. The risk-benefit ratio of the immunosuppressives has to be considered, and cost effectiveness is utmost important. Now, how to do the rational use of the available molecules and how to target these treatment options if the disease is localized. And here we have topical steroids and calcineurin inhibitors. You can also take the help of systemic steroids. Phototherapy is a gold standard, has multiple modalities of action. Nowadays, there are excimer lasers that are available, and a grafting techniques which are also available. And this is a kind of a chart which is quite useful. And these are various topical molecules and their approximate cost. So if you look at the traditional steroids and the soralins, which we often use in these patients, they are quite affordable to your patients. But if you look at the calcineurin inhibitors, that is tacrolimus, they are quite costly. So depending upon the budget of the patient, you can choose one of these molecules. And these newer molecules like latanoprost and then decapeptides, they are highly costly, like they are more than 1,000 rupees. So in my practice, I keep them as reserve drugs, especially for sensitive patients and those who are not responding to my conventional therapy. These are the oral medicines. Again, the oral therapy of psoriasis are quite cost effective and they are easily available. Oral steroids in a spreading disease, again, for a spreading disease. And these are the molecules, but now there are more therapies that are available to these patients. Coming to the phototherapy, you can have a narrowband UVB or a PUVA therapy, excimer light, which is a targeted type of light therapy which can be used for selective patches, and there is something called as Puvasol therapy. So this to a patient only. The patient takes sunlight enhanced pigmentation after taking psoriasis. Short 2 or 3 slides about the surgical management, and I will end my presentation. So if the patient is having a stable patch, normally the surgery is demanded before marriage. So patients are going to say, I am getting married in 2 months and you please do a surgical treatment so that my patch is not seen. So don't fall prey to these kind of requests. Make sure that the patch is stable. Then first line is always medical line. So don't jump onto the surgery as the first line. Segmental vitiligo patients do very well with surgical option, and it is kind of a cure for these patients. So do choose this option for these patients. The recipient skin should be normal. It should not be lichenified. It should not be red. Patient should not have any history of keloid, and there should not be any active infection where you take up when you are decided to take up the surgery as option. And these are the surgical methods which are commonly practiced: suction blister, non-cultured melanocyte suspension, and mini punch grafting in resource poor settings. And this is how a suction blister is created, by using just 2 simple injection syringes. And this particular blister roof acts as a graft. And in the recipient area, you scrape the skin and put this blister roof as a graft there, and it gives really good results after blister grafting. Now, I was talking about a segmental vitiligo. Now, if you have a lesion which is like this, more widespread, many patches are there, doing a graft is little difficult. So such kind of patients, you can choose something what is called as non-cultured melanocyte suspension. So advantage of this technique is that a small skin can cover a larger surface area. So if you have 1 centimeter skin as a donor skin, from that skin, you can separate the cells and you can cover about 6 or 7 centimeter of the vitiligo area. So smaller donor area is able to cover a larger size, and this is the big advantage of this particular technique. And a color match after this is really good, and this is available in few major centers in the city of Pune. So you can definitely advise your patients to go for this technique, especially so in a segmental type of vitiligo. And we did this, and he is nicely repigmenting after this non-cultured melanocyte suspension. Now, in centers where nothing is available, a simple biopsy punch of the size of 1.5 millimeters can be used to harvest the grafts from the donor area and transplant them in the vitiligo area. And this technique now is not commonly practiced, because, and especially on face, it should not be done because it causes what is called as cobblestoning. So this is about the surgical treatment modality. Now, these are some of the antioxidants which are available, which reduce the oxidative stress to melanocytes. I have already discussed about the immunosuppressive options in spreading vitiligo. And do not forget the sunscreen or a protective clothing for the patient. And as I was suggesting, a patient who has patches on a cosmetically important area, do take help of these camouflage creams which are available. You can mix and match two colors, and believe me, like if patient uses it properly, you will not be able to make out that this patient has a patch on vitiligo. So finally, the take home from this today's lecture is that remember that the treatment is very challenging. The results are unpredictable. So try and use combination therapy for your patients. Psoralins and phototherapy are still the gold standard and they stand the test of time. Cost-effective therapy, I am emphasizing again and again, it will help for the better compliance from the side of the patients. And it is a psychosocial issue. So don't look at it as something which is going to pay you for your investment. Look at it in a more gentle manner and have a sympathetic approach. And at times you may give 1 or 2 free consultations to these patients, because these poor patients are actually your patients rest of your life. So just be sympathetic to the vitiligo patients. With this, I conclude and I thank you very much for your patient listening. Thank you so much.
Thank you, Dr. Dhanashiri Bhide. Excellent presentation. And most of the questions you have already answered. So may I request Dr. Deshmukh sir to felicitate you.
I think I was quite on time. Thank you, sir.
Yes, definitely, definitely.
This is e-bookie for you.
Thank you so much, sir.
There is a IMA Uparna, special IMA Uparna for you.
Thank you.
Yes.
Yes, thank you very much.
Thank you, Dr.
Thank you.
You can stop sharing your screen, ma'am.
I will.
May I now request our next speaker, Dr. Sanjay Mankar. He is again my batchmate from BJ Medical College. So welcome Dr. Sanjay to IMA. He is professor in pediatrics and pediatric infectious disease at Bharati Vidyapeeth Medical College, a very senior practicing pediatrician at Singhangad Road. He is consultant pediatric infectious disease and past president of IAP, a very busy person. So thank you for taking out time for today's webinar. Over to you, Dr. Sanjay.
Thank you, Gitanjali, for a kind introduction. Good afternoon to all of you. And at the outset, I would like to thank organizer Dr. Deshmukh sir, Dr. Ingre sir, Dr. Shirsagar madam, Gitanjali, and all the organizers for the invite. Let me start sharing my screen. Okay, is my screen visible?
Not yet. Not yet.
Is it
Yes,
visible
now?
now?
Yes. Yes, it is visible. Go to the slideshow mode, please.
Yes. So skin is the important mirror of all the internal diseases of the body. And certain skin lesions are very particular about various internal diseases. And we can directly, if we have a knowledge about these dermatological lesions, we can directly clinch the diagnosis without making much investigation. You can confirm that your diagnosis after doing certain relevant investigations. Various systemic diseases like infections, connective tissue disorders, neurocutaneous syndromes, gastrointestinal problems, vasculitic syndrome, endocrine disorders, nutritional disorder, metabolic disorders like Gunther's and all, hepatic, renal and malignancies, all of them may have a various particular skin lesions on a body, and their knowledge is extremely important. It is very difficult to enumerate even all these lesions. It is beyond the scope of this 30-minute talk. So I will try to be very precise and will try to see few cases only rather than enumerating all the lesions. So let's begin with the infections, which is a topic of my interest. So here is the first child who has come to me with the complaint of fever of 5 days duration. He also had a red eyes, and he had a lymphadenopathy, and he had a rash, which is a maculopapular erythematous rash, later on turning to be a urticarial rash. But the urticarial rash normally fades, but this has not fed up within a time. And the child also had a vomiting, loose motions, abdominal pain, and there was a history of COVID in the family. So this child, this is a very common scenario nowadays. We call it as a multisystemic inflammatory syndrome, which is associated with COVID-19, and the dermatological manifestations are mainly urticarial rash, which doesn't fed up, or you may have a maculopapular rash, which is common. It's a multi-system involvement, so gastrointestinal tract is involved. Sometimes you get an involvement of CNS also, you get an involvement of cardiac tissues, which is very common. So you must do a 2D echocardiography to find out of evidence of myocarditis and coronary artery dilatation, which is very important. But earlier you can just think of this when you have a very high CRP, high D-dimer, positive pro-BNP test. So all this ferritin which is raised is highly suggestive of multisystemic inflammatory disease, which is associated with COVID-19. If it is a mild form, it is routinely treated with just a dexamethasone or oral corticosteroid. If it is severe, it is treated. Severe means it is with the involvement of other organs, including heart, liver, or any other organ respiratory. Then you need to give IVIG. That's a drug of choice. So that's a multisystemic inflammatory syndrome associated with COVID-19. This is an 8 days old neonate which has come up with the fever of 2 days duration. Incidentally, we come to know that the mother also had a fever of 3 days duration. The baby was having respiratory distress, and so we thought this could be a sepsis because the baby's hemogram showed a lymphocytosis and also thrombocytopenia. But on the day 3 of the fever, the child classically developed a hyperpigmented lesion all over the body, especially on the face, and the hyperpigmentation was more common on nose. So this is classical brownie nose appearance which happens with the chikungunya. So we thought of chikungunya. We did a PCR of this child, and the PCR for chikungunya was positive, and also the mother's IgM for chikungunya was positive. So this brownie nose appearance is very typical for chikungunya. The very next child who had come to you from the village area, this has traveled to the Bhide district, came with a high-grade fever, and the rash appeared on the body. On the 4th day, the rash was initially macular, but later on involved almost all part of the body, became a spotted like rash involving palms and soles, and become a palpable purpura rash. So that's the classical of the child. Also had a hepatosplenomegaly, thrombocytopenia, and this is a classical nothing but a rickettsial fever. So the rickettsial fever, the skin manifestations are very important. They may be present in 60 to 70% of the cases. The child may have a rash, which is a palpable purpura distributed all over the body, which is important. But once the rash is neglected, sometimes you may think that this can be a meningococcemia or any other kind of a viral rash. Then the child may progress later on, like this child who is hospitalized in the Bharati and was having a meningococcemia like picture. We treated for meningococcemia, but the child also had an encephalitis. His IgM for rickettsial fever was positive, and you can see later on the gangrenous changes occurs because of the vasculitis. So the chikungunya, the rickettsial rash, if neglected, can lead to various vasculitis changes, can lead to gangrenous changes in rickets. They also known to cause various problems with the ears, also known as a Kankapé disease in a certain part of the country. It also known as Biptea in certain part of the country. So rickettsial disease, it's a very important, and you cannot miss the diagnosis of the rickettsial disease by the dermatological manifestations. Another child who had presented to us with a prolonged fever of 12 days duration, that we did an investigation slot, but there was no clue to the thing. We just took out the shirt of the child, and there was a big ishar which was there, and this ishar was highly suggestive of something called as a scrub typhus. So whenever the cigar bite is there, the classical ishar along with the hepatosplenomegaly, fever with chills, is highly suggestive of scrub typhus, which is caused by Oriental Sugmushi. And the IgM for scrub typhus was positive in this child, was successfully treated with the doxycycline for 7 days, and the child became all right and the ECR do disappear. It is very difficult to find out sometimes the ECR because they are always on a hidden part like scrotal area, scalp, and any other hidden side. This child presented with the plaque-like lesion on the face, mild fever, and almost edematous plaques on the body, and a satellite lesion. A careful examination was done, which shows that the child also has got a hypoesthesia in this area. There was no sweating from this area, and the child's great auricular nerve, temporal nerve, popliteal nerve, sural nerve, all were palpable. This child was in fact in a lepra reaction, which was confirmed by doing a biopsy of this lesion, which showed a classical granulomas. And though the skin clip was negative because it's a paucibacillary disease, it was successfully treated with the dapsone, rifampicin, and clofazimine. And this is the same child after the treatment showing the regression of the patch. So this was classical Hansen's disease. This child, who is 2-year-old child, presented with a fever of 2 months duration. The child had a fever 2 months duration, mild splenomegaly, clubbing, and on examination he had a maculopapular rash and a rash which was there on palms and soles, which was suggestive of a vasculitic rash. We thought this could be a rickettsia, but the next day the child had a conjunctival bleeds also. So this, we thought this can be a endocarditis. So the endocarditis may have a vasculitic rash. So this 2D echo was done, which showed a classical vegetation. The Genevese lesion, Osler's nodes, and rot spots are other features of the endocarditis. This child's Viridans streptococci came positive, and he was successfully treated with the ceftriaxone and gentamicin. So this is the infective endocarditis. The child who has presented with a plaque lesion with the dry hyperkeratotic lesions on limb. We did a biopsy of this and it was nothing but a tuberculosis verrucosa cutis. Other features of tuberculosis of the skin may include a lupus vulgaris like this child, which starts as a apple jelly nodule, which later on give rise to a classical ulcer, which spreads, and it may involve almost what are the parts of the body. It is more common on a facial area. You can see how the eye is affected. The total eyelids are destroyed. So that's the lupus vulgaris, which heals with scarring. And this child also had a gibbus. So that's the tuberculosis of spine. The child also had a disseminated tuberculosis, also require management with the 4-drug treatment. So tuberculosis can have, the skin tuberculosis may have multiple manifestations like a scrophulodderma, lupus vulgaris, tuberculosis verrucosa cutis, papillonecrotic tuberculosis, tuberculosis cutis orifices. So lots of forms are available, and you must look into the systemic manifestations as well as the dissemination of the tuberculosis. So infant who presented with a high fever, irritability, and skin lesions. When we asked the mother said, you touch the child cries because of the extreme skin tenderness. The child also had erosive lesions and a positive Nikolsky sign. It's the classical for staphylococcal scalded skin syndrome. The staphylococcal scalded skin syndrome, if you look at the face of the child, the lesions are peri-orificial lesions around the eyes, around the nose, around this thing, giving rise to a sunray appearance, dry keratotic skin with a lot of scaling, which is there. Again, a systemic disorder because caused by staphylococcal toxin. So that once the toxin are released, the child gets high-grade fever, may land into electrolyte imbalances and shock because of this. So need to identify as early as possible and try to treat with the cloxacillin, vancomycin, or clindamycin as a drug of choice for a staphylococcal scalded syndrome. Child presenting with a high fever and right on a day 1 getting a rash on the body, which was erythematous rash, giving almost a reddish appearance to the body, and the rash was having a typical sandpaper appearance, which started initially on the nape of the neck and on the shoulder, and involving the flexular parts of the body, and then classical strawberry tongue was also there. So this is classical for something called as a scarlet fever caused by group A beta hemolytic streptococci, and you need to treat it as urgently as possible because it can lead to post-streptococcal glomerulonephritis or a rheumatic fever or a toxic shock syndrome, which is a manifestation or a complication of scarlet fever. And later on, the child may get a dermatological manifestation as a desquamation of the skin literally comes out in the form of a sheets around on the hands and the legs. So that's the manifestation. The scarlet fever can lead to something called as a toxic shock syndrome, and the toxic shock syndrome may manifest as a sunburn appearance of the skin, which is again seen with this kind of the lesion you cannot miss in your practice. That's a meningococcemia, also known as a purpura fulminans. The child initially starts as just a viral fever like a symptoms, cough, cold, coryza, and a fever. Later on gets a erythematous maculopapular rash or urticarial rash, which later on becomes a purpuric rash and called as a purpura fulminans. Very serious condition, even in the best setup has got a 50% mortality. May be associated with meningitis, may not be associated with meningitis, but try to treat with ceftriaxone plus vancomycin as a drug of choice for meningococcemia. Can be proven with the blood culture or the culture of the other tissue sites. The child coming to you with a fever, he had a fever of 4-5 days. Somebody has given amoxicillin and the rash appeared. The child also had, you can see a lymphadenopathy, which is marked over there, the lymphadenopathy, and also hepatosplenomegaly as a hallmark. The child has the red tongue, also he has a tonsillitis. So this is the classical rash which appears after giving a amoxicillin or ampicillin, is also known as ampicillin rash or infectious mononucleosis. So many of the skin rash may appear because of the variety of the lesion, including measles, chickenpox, hand, foot, mouth disease, and virtually any virus can give rise to a rash. We are not going to cover all this in this thing. We switch on to the connective tissue disorders, which can be a common manifestations of the dermatological disease. The child who is coming to with a fever, rash on the body, photosensitive area, rash on a photosensitive area, especially on the malar area, a butterfly rash along with hematological manifestation like anemia, urine mesh or hematuria, and it may also have generalized weakness, lymphadenopathy, as well as joint involvement is a typical of systemic lupus erythematosus. You can confirm the diagnosis by doing ANA, DNA or biopsy, whatever is there. Apart from this malar rash, which is very important, the malar rash is classical butterfly rash, which happens on the nasal bridge. It happens on the cheeks. It doesn't cross the nasolabial fold. That is a very important, that this rash of SLE will never cross nasolabial fold, while the rash of dermatomyositis may cross the nasolabial fold. This rash will heal with scarring, and it is a photosensitive rash. So that's the feature of SLE. Apart from the malar rash, you may have a simple, this child started with a vesicular lesion, which leads to ulceration, and later on scarring, which heals with the small scar like this. The child also turned out to be SLE, also had a prolonged fever. This is again child with discoid lupus erythematosus, which is a chronic lesion on a face with the elevated margin. So that's the discoid lupus erythematosus. This 3-year-old child presented with high fever, generalized weakness, muscular pain, muscle tenderness, and also found to have a periorbital edema as well as a rash on face. So that is a classical heliotrope rash which is seen in a dermatomyositis. So the dermatomyositis can present with a heliotrope-like rash as well as small papules on the dorsum of the fingers known as Gottron's papule, and sometimes you may get a shawl sign, which is a sensitive photosensitive areas. You may get a rash on the body. When the rash is there on neck as well as on trunk, we call it as a positive shawl sign. So these are the important dermatological features which are seen in dermatomyositis. So various connective tissue disorders like SOGIA, systemic onset juvenile idiopathic arthritis, may present with a salmon colored linear or a circular rash on extremities as well as trunk. Systemic lupus erythematosus, we have seen a classical Malar Rash. Dermatomyositis, heliotropic rash. Morphea may have a saltpeter appearance of the rash. The Behçet syndrome may have erythema nodosum as a classical feature, while Retter's disease may have a keratoderma planoregica, and the sarcoidosis may have a erythema nodosum as an important feature. This is a saltpeter appearance of the rash, where the lesion starts as a indurated lesions, later on leads to scarring, and that leads to hypopigmented lesions. So this is a classical saltpeter appearance which is seen in the morphea. When you have a lax skin, there is a lot of atrophy of the skin, scarring, and hyperflexible joint. You must think of something called as a Ehlers-Danlos syndrome. The child presenting with aphthous, recurrent ulceration, erythema nodosum, and uveitis has to be a Behçet syndrome. So we switch on to the gastrointestinal manifestations. The gastrointestinal tract may get affected in various ways. The skin lesions are very common with inflammatory bowel disease, that is Crohn's disease and ulcerative colitis. There may be a direct skin lesions, like you may have aphthous ulcerations, you may have granulomatous cheilitis, or you may have a perianal ulceration. So that's the very common. And immunological reactions like erythema nodosum or pyoderma gangrenosum are also common with the gastrointestinal diseases. So this child, again, very strangely presented with a nodular lesions on genital area. With this nodular lesion turned to the abscess formation. These abscess were recurrent, non-healing. Multiple courses of antibiotics were given. Later on, the biopsy of this lesion was done, which was suggestive of tubercular granulomas. So she was started on AKT. The child also had severe weight loss. The child was failure to thrive. Height was very less than 3rd centile. So the child was treated for tuberculosis, but there was no improvement at all. In spite of anti-tubercular treatment, the child was losing weight. So when we saw very carefully, the child had a big skin tags on perianal area, the skin tag along with the discharging sinuses. This was a highly suggestive of something called as a Crohn's disease. So the Crohn's disease may manifest with discharging sinuses, abscesses, and multiple skin tags in this area. And this child was again been switched on to corticosteroids and azathioprine for the further treatment. And the biopsy was confirmed as a Crohn's disease, and even the sigmoidoscopy was done to prove that this is a Crohn's disease. This child is slightly unusual child. He presented with fever and respiratory distress. We did X-ray. It was almost suggestive of a miliary tuberculosis. So we thought this can be miliary tuberculosis, and we saw at the hands of the child, we found a pustular lesions and multiple scars which were there. And the child also had seborrheic dermatitis, which mother told that this is there since last almost a year and it is not at all healing at all. So seborrheic dermatitis, the child had got a pulmonary infiltrates, and the child was again having a dermatological lesion. So we examined the scalp carefully. There was a swelling and there was a tenderness. So again, the X-ray was done. That the X-ray showed a sclerotic lesion which was there. So again, the diagnosis of Langerhans cell histiocytosis was suspected, and it was confirmed by doing a biopsy. So the seborrheic dermatitis, or even a form of diaper dermatitis which is not healing, is highly suggestive of a Langerhans cells histiocytosis. Child also had a failure to thrive and other organ involvement in form of bones, liver, hematological problems, malignancies can occur. So that's the feature of Langerhans cells histiocytosis. Another child showing the same manifestations of Langerhans cells histiocytosis with the lesion in the diaper area and axillary area. So again, Langerhans cells histiocytosis. Both the child were treated with vinblastine and corticosteroids. So vasculitis syndrome again have a multiple manifestations, dermatological manifestation. This child presented with high-grade fever of 6 days duration. He received multiple antibiotics. On examination, the child had cracked lips, erythematous lips, strawberry tongue, and also a rash on the body. The rash was measles-like rash on the body. He also had mild lymphadenopathy. There was hand changes, edema of the hand, which was there, and desquamation. So this is very classical for something called as a Kawasaki disease. The Kawasaki disease may be diagnosed by fever of more than 5 days duration, oral changes, non-purulent conjunctivitis, and various skin changes. So either measles or a scarlatiform rash is very common with the Kawasaki disease, and the drug of choice for all the practical. There is no test which can detect the Kawasaki disease. So it's a clinical diagnosis. You can treat it with the IVIG. The child, 6-year-old child, presented with fever and abdominal pain and vomiting. We were wondering whether this is the appendicitis or what, but the next day the rash appeared on the body, which was erythematous macular rash. Initially become a palpable purpura rash, and suddenly there was a swelling of the ankle joint. So this was highly suggestive of Hinoch-Schönlein purpura. So Hinoch-Schönlein purpura may manifest as a rash which is distributed mainly on lower extremities, buttocks, and upper extremities, sparing trunk and face, and the rash is classically a palpable purpura rash. There is no thrombocytopenia. The platelet count is always normal in Hinoch-Schönlein purpura, but the child may have a systemic manifestations, like they may throw convulsions, they may have severe abdominal pain, paralytic ileus like picture, and even GI manifestation, abdominal vomiting, pain, vomiting, etc. So that's a Hinoch-Schönlein purpura. The child has a reddish erythematous nodular lesions, which is on lower extremities, known as erythema nodosum. Erythema nodosum, it's not at all a diagnosis. Erythema nodosum is a manifestation of some systemic diseases. In the pediatric age group, we commonly see these with the streptococcal infections. We may see it with the tuberculosis, leprosy, brucella, leptospira. We also commonly see it with the Epstein-Barr virus infection, mumps infection, or you can see with the sarcoidosis and other Behçet and all as a erythema nodosum as a manifestation. They are mainly present on the extremities. They are routinely reddish, or they later on become violaceous or brown in color, but they do not ulcerate. So that is the feature of this child. Presented with fever and lesions like this. The lesions were initially yellowish pink in color, later on become brown, rubbery in consistency, and there was, once you stroke this skin, there was classically urticaria appearance. We call this as a Darrier sign, and the Darrier sign is a feature of mastocytosis, which may come as a solitary mastocytic lesion, or it may come as urticaria pigmentosa lesion. So the child may have a multisystemic manifestation in form of vertebral column involvement, osteolytic lesion, or involvement of skull. He may have a hepatic lesion. So these are all mastocytosis presenting as skin lesions. So neurocutaneous syndromes are a very common manifestation. The child presented with convulsions. The child was treated for the convulsion, and when we look at the face, the child had a classical angiofibroma. So these are small angiofibromas. These later on come together and form a plaque-like lesion. So this is the angiofibromatosis, which is seen. And the child also had a hypopigmented lesion on knee, as well as a hypopigmented lesion on thigh. So this is a very classically known as tuberous sclerosis. So this is Ashliff's macule, which is there. The other features are confective macules and a chagrin patch. So once you see a chagrin patch or a Ashliff macule, that's the diagnosis of tuberous sclerosis. This child's MRI was done, which shows a dripping candle appearance, which shows a tubers in which are protruding into the ventricle. So that's the typical dripping candle appearance which happens with the tuberous sclerosis. The child also presented with status epilepticus. So they had multiple seizures. We tried to treat it, but the child didn't respond. So status epilepticus is an important manifestation. When we look at the child's face, he had a big hemangioma. So this is very classical for something called as Sturge-Weber syndrome. So here the child also had a rail tract calcification in the on MRI. The child coming to you with the multiple gray brownish color lesions, which is seen They are classically called as a cafe au lait spots. The cafe au lait spots are seen all over the body. The cafe au lait spots is a hallmark of neurofibromatosis, but they may be seen with the other conditions, like it may be seen with the tuberous sclerosis, ataxia telangiectasia, McCune-Albright syndrome, or it may be seen with the other like Bloom's disease, Fanconi's, etc. So they are not classical for neurofibromatosis, but they are present 100% in case of neurofibromatosis. These are the classical neurofibromatosis. So if more than six cafe au lait spot of size of more than 5 millimeters in a pre-pubertal area, or if they are more than 15 millimeter after in the post-pubertal area, it is classically suggestive of neurofibromatosis. So this child has classical neurofibromatosis. This is classical incontinentia pigmenti with the appearance of the vesicular lesion along the line of Basco. So we can see the vesicular lesion. These lesions later on ulcerate and they heal with some initially a verrucous lesion, later on atrophic lesion, and hypopigmented or hyperpigmented lesion. That is classically incontinentia pigmenti also may have a neurological manifestation and other manifestation. So other neurocutaneous syndrome also do, like linear nevus syndrome, von Wipple-Windu, all may have a dermatological manifestation. Few endocrine diseases can have, almost all the endocrine diseases can have. This is classical child presenting with hyperpigmented area, velvety skin appearance, and hyperkeratotic area on nape of the neck, anterior as well as posterior part and the side of the neck, as well as in groin and axilla. So these are classical acanthosis nigricans. Acanthosis nigricans commonly seen in obesity. They are also seen with the insulin resistance. They are also seen with the, you have to rule out various endocrinopathies where acanthosis nigricans or rheumatis mellitus, hypothyroidism, and other features. So that's classical acanthosis nigricans. The child coming to with the hyperpigmentation of the knuckle area, hyperpigmentation of the palm soles, as well as oral cavity and the scars, along with hypotension, hypoglycemia, hyponatremia is a classical feature of Addison's disease. The child having a telangiectasia lesion in which starts at around the 3 to 4 years of age in eyes, along with the oculogyric crisis, along with the ataxia, and this telangiectasia occurs also on nose, nasal bridge, then on cheeks, and then on ears is a classical feature of ataxia telangiectasia syndrome. The child also has a sinopulmonary infection because the lower immunity, also has a cerebellar ataxia and a neurological manifestation. So this child presented with a large hemangioma-like lesion. We thought this could be a vascular malformation, but the child was looking very pale. So we did a hemogram which shows a thrombocytopenia and a severe anemia. So we had asked Dr. Tolat sir to look at this case, who diagnosed this as a Kasaba-Merritt syndrome. So the Kasaba-Merritt syndrome may present as a hemangiomatous malformation with thrombocytopenia, microangiopathic hemolytic anemia, as well as consumptive coagulopathy. The child was started on steroid and propranolol, but the child lost to follow-up. So we didn't have a record of this child. Another child who was diagnosed at birth, he presented with a hemangioma of the left lower limb, but the left lower limb was looking much bigger as compared to the right lower limb. So this is classically seen with the triple Tennoni-Weber syndrome. The child also had, you can see the vascular malformation which is associated with it. The child also had a bony hypertrophy and subcutaneous tissue hypertrophy. This child underwent sclerotherapy. The child still complained of the leg pain. So triple Tennoni-Weber syndrome is one of the malformation which can be commonly seen. Again, this is very also known as hereditary hemorrhagic telangiectasia. They commonly present to us with epistaxis and hematemesis, and they have a multiple telangiectasia which are distributed almost all parts of the body, including GIT, liver, brain, etc., also known as Osler-Rendu-Weber syndrome. This child presented with high fever and vomiting. He had, when we saw at him, he had a marked icterus. You can see the child has a icterus, a liver enlargement, and the next day the child started having a erythematous maculopapular rash on the body, which started desquamating very early. And on inquiry, the child was on carbamazepine. So this is when we did a hemogram of this child. It classically showed lymphopenia and also eosinophilia. So this is a classical DRESS syndrome, drug rash with eosinophilia and systemic symptoms, which is suggestive of a DRESS syndrome, which is a classical drug reaction which occurs with either sulfonamide, dapsone, or commonly we have seen with carbamazepine. So this classical DRESS syndrome, and the child may have a multiple systemic involvement in form of a lung involvement, may have a cardiac involvement, have a liver involvement, GIT involvement, and can land into shock. This child in fact landed into the renal failure and require ICU care, and was successfully managed with the steroid and removal of the drug. So that's the DRESS syndrome. Another child with the drug reaction, Stevens-Johnson syndrome, presenting after herpes simplex infection. So the classical iris or target lesion of the on the skin are the diagnostic, which involves the, so very few drug rash, very few rash involves the palms and sole. Drug rash is one of them. The classical iris or a target sign, along with involvement of the oral mucosa, involvement of conjunctiva, rectal mucosa, vaginal mucosa, is all suggestive of Stevens-Johnson syndrome. Lastly, so nutritional manifestation, the child presenting with chronic diarrhea and has this kind of rash, which is in suggestive of a peri-orificial involvement, dry scaly lesion and a psoriatic-like lesion, which is there, reddish in color, erythematous psoriatic lesions on buttocks and lower extremities, perianal area with diarrhea, is highly suggestive of acrodermatitis enteropathica, which is zinc deficiency because of the failure of absorption of the zinc due to genetic defect. Is classical. Sometimes the lesions may be vesicular or verrucous lesions. In case of acrodermatitis enteropathica, the acral distribution of the skin lesions, that's why it's known as a acrodermatitis enteropathica. You can confirm by zinc levels which is less than 50, serum alkaline phosphatase which is low, and the child can be treated with the zinc 3 milligram per kg. So that's the acrodermatitis enteropathica. Everybody is aware of this kwashiorkor. The kwashiorkor may change, present as hair changes, which are the hairs become dry, silky, they become depigmented. The kwashiorkor word itself means a brown haired boy. So they may show flax sign, and later on you may get an edema and the skin becomes dry, thin, scaly. So that's classical kwashiorkor lesions known as either crazy pavement dermatosis or flecky pen dermatosis. Child presented with developmental delay, tremors, and severe anemia. So we could say this can be a anemia tremor syndrome which is there, but the child classically had very hyperpigmentation of knuckles. So this hyperpigmentation of knuckles along with the developmental delay is very highly suggestive of vitamin B12 deficiency, and we confirm this by doing a vitamin B12 level, and the child successfully treated with B12 injections, and the child's developmental delay also disappeared. So knuckle pigmentation is very highly suggestive of B12 or megaloblastic anemia. With pellagra is another common nutritional deficiency which can happen. The child may have a rash which is initially erythematous rash with the scaling mainly on the photosensitive areas on the hands, feet, and when it occurs on the neck, it looks like a castle's necklace. So castle's necklace is one of the feature of the pellagra due to the niacin deficiency. So the last slide, I think, is the child presenting with xanthomas. So these are the classical xanthomas, deposition of lipid tissues in a dermis as well as in subcutaneous tissues, which is highly suggestive of xanthoma. The xanthoma are commonly associated with high cholesterol level. Later on, they become nodular lesion, which are brownish in color. So they may be associated with familial hypercholesteremia. So multiple, so classical xanthomas. Atopic dermatitis and seborrheic dermatitis may have a different skin. So this is classical seborrheic dermatitis. Why this we treated with multiple therapies, but it was not healing, and this is commonly associated with immunodeficiency. So this kind of seborrheic dermatitis, which is resistant to treatment, is commonly associated with immunodeficiency. The child may have a multiple infection also, is failure to thrive, and may have a multiple infections. So that's so points to remember. The skin is a mirror of the various internal diseases. There are a few signature dermatological lesions of the various systemic diseases, and the correct knowledge about these diseases is always rewarding at it, which clinch the diagnosis, and employ your knowledge of interrelated condition to create a holistic approach to have a good patient care. Thank you very much for the patient hearing.
Thank you, Dr. Mankar. It was an excellent presentation. I myself, being an ophthalmologist, always say that eyes are windows where we can diagnose many systemic conditions. And you correctly mentioned that skin is the mirror of all the systemic conditions. It was excellent collection and documentation of various. I would suggest you can have an color atlas of these photos for benefit of everyone.
Yeah, definitely. Thank you, Gitanjali. Thank you very much.
May I now request Dr. Deshmukh sir to felicitate you, Dr. Mankar. Please accept.
Yes.
Virtual it is.
Yes. I just stand up. That's all.
Okay.
Thank you, sir.
And there is a IMA Uparna for you.
Yeah, thank you. Thank you.
Thank you very much, Dr. Sanjay.
Thank you.
May I request you to stop.
Yeah, I just.
Now for the next session, we are going to have basic life support training by Dr. Varsha Shinde. Dr. Varsha Shinde is MBBS and MD Anesthesia from BJ Government Medical College. She is working as professor and head of the Department of Emergency Medicine at Dr. D.Y. Patil Medical College, Pune. She is BLS, ACLS, AHA course director since 2008. She is ATLS course faculty since 2012. She was a member of expert core committee to contribute to the manual of first aid for layperson approved by Ministry of Health, Government of India and WHO. That's really great, Dr. Varsha. Her areas of interest is resuscitation in emergency medicine. And today she is going to train us for basic life support. Over to you, Dr. Varsha.
Thank you for your kind words, Gitanjali. I'll start my screen sharing. Is it visible?
Yes. Just start sharing. Yes.
Okay. So all of you are skin specialists as I'm told, and this is regarding actually basic life support is, you know that cardiac arrest is the greatest emergency of life. And what is to be done? What is the algorithmic approach to go about it? That is what I am going to tell. Next slide. So you all know that cardiac arrest can happen at any place. So it can happen at home, when you are waiting for a bus, or anywhere on the, say you are gone for swimming, gym, anywhere. So what to do if you may not be having any equipments with you? And then how do you help the victim? The victim can be your own family member. And then as a doctor, you must know what is to be done in a algorithmic manner. So I'm going to just state about the scientific knowledge, what to do. Being medicos, I think to educate the community about the recognition and how to respond is very, very critical. So that is why this course is very, very important. I'll take a case scenario. Suppose a middle-aged gentleman has collapsed while he is waiting for the bus and you happen to be present there. So I want you to think, what will you do? This is all about saving life. So all those who are keen on saving life, they can please attend it carefully. So this is the scenario which we will take forward in a step-by-step manner. So American Heart Association describes what is called as a chain of survival. So if you do these actions in a sequential manner, these are the links of the chain. And if they are done in a sequential manner, there is a highest chance that you can save a victim. So the first chain of survival is activation of emergency response, then high quality CPR, defibrillation, advanced resuscitation, post cardiac arrest care, and recovery. Now here, time is of essence. Actually, Gitanjali, is it possible for me to have the interaction? Why time is of essence? Can somebody tell?
They can answer in the chat box.
Oh, they cannot on the audio and tell?
That might be difficult, Dr. Varish.
Okay. So I want you to think that here the time is of essence, because how much ever the world's finest doctor comes for your help, after 3 minutes of cerebral hypoxia has happened, it is of no use, because all of you know that the neurons die for good. So that's why time is of essence. So afterwards, if you get a expert help, and even if your heart starts, then what you get is a person who's in coma, who's dependent on vasopressors, on ventilatory support, on urinary catheter, and all those things. So what our interest is, cardiopulmonary cerebral resuscitation. And that's why timely help is of essence. Now, what is this help when you don't have the equipments? This is the chain of survival in terms of picture. So outside the OHCS stands for outside the hospital cardiac arrest. Here you can see early activation of emergency response system, high quality chest compressions, earlier defibrillation, and then the advanced care. So in hospital, because all of us are medicos, in hospital cardiac arrest, there is an extra chain, or it is different, that early recognition and prevention. So you should be surveillant about who can arrest. So if you recognize this person and send him to the critical care unit, or you do the steps to prevent the arrest, then that is of essence. You will be surprised to know that despite the recent gains, less than 40% of the adults they receive the layperson initiated CPR, less than 40%. This figure is really bad. And fewer than 12% have AED applied before the EMS arrival. What is this AED? It is automated external defibrillator. So you can see that 12% we can make it higher by training the people. And only 10% of the adults who have received who have sustained out of the hospital cardiac arrest, they make it to hospital discharge. So this also again a figure. If BLS is given in a timely manner and efficiently, these numbers can increase. So what are the main components of basic life support? It is the chest compressions, patent airway, adequate breathing, and defibrillation. The sequence is CAB, that is circulation, airway, breathing. Actually, because if it was interactive, I would have asked that we are taught in medical practice as resuscitation ABC. Now here, why are we saying CAB first? So because of the lack of time, I will only give the answer that when the heart stops, that time the airway and breathing is still going on. So when you give the compressions first, you give only 30 compressions and then make the airway patent and give 2 breaths. So you are delaying the airway management only by say 17 to 18 seconds. That is the scientific reason why you should go for the compressions first. Whatever was wrong first, you have dealt with that. So you come across the person in this manner, somebody who's unresponsive. Either you witness him collapsing in front of you, or you come across somebody who's lying in this manner. So what are the steps? Step 1 is to make that whether the scene is safe for you to help. Internationally, nobody will ask you that you endanger your own life to help somebody. So you check that whether the scene is safe for you to enter. After making sure, then you check by tapping on his shoulder and asking him verbally, are you all right? So if the person responds, well and good. If the person is unresponsive, possibly that he may be in cardiac arrest, in such cases, the first thing you must do is you can see whether somebody can help you. If you see somebody, you can look into that person's eye and you can tell him that, hey, you activate the emergency response system and get an AED. Or if there is nobody, you can use your own smartphone and dial the toll-free number. As of now, for Pune, it is 108, and you can tell him, you can tell where the situation is, and you can ask the help. You must have seen the videos which had gone viral, where a person is calling 911 in a developed country and getting the AED by drone facility. So it will take maybe many more years even for Pune, but this is what is call for help. Now, why do we call for help? If you have the knowledge, or if you are a medico, why do you still need to call for help? This is my question. So the specific answer is, you alone cannot undertake a resuscitation work for a long time. And the most specific treatment of cardiac arrest requires defibrillation, that is the automated external defibrillation. So you are asking that specific help in time. And that is why after the unresponsiveness, when you have detected that somebody who is unresponsive, you are calling for help. I think I am clear. So after that, you have called for help. Now you are going to do two things by yourself. That is, one, you are going to look for a carotid pulse and you are scan for respiration. How long should you do that? Just 10 seconds, not more than 10 seconds. So for a lay person, you can teach how to check the carotid pulse. You can teach them that in the center, there is a windpipe, there is a prominent muscle. In the middle of the neck, if you go between the carotid and the sternomastoid, you can feel for the pulsations only for 10 seconds. If these pulsations are absent, it is a sign that the person is having cardiac arrest. You have to scan for respiration. It really needs coaching. You can tell the lay person that they should observe the person who's sleeping in their family member. The silent abdominal motion, if they observe, then they can make out whether there is absence of breathing. So these are the two things. What if somebody has a confusion whether the pulse is there or not? Then the guideline says that if you are confused, if you are not sure that it is your own pulsation or the person's pulsation, take it as absent and go ahead and treat. So if you have done two things, you have three options. One, the pulse is present and the person is breathing also normally. What to do? He was just not responding. So you have already called the emergency response system. You wait for the team to come and take over this patient. Till the team comes, you have to keep monitoring the pulse and the respiration. At any time, if it disappears, you have to go ahead accordingly. So first option was very easy. You have called the ambulance. Second option is, if the person is not breathing, but he is having the carotid pulse. So this condition is called as pure respiratory arrest. And in such cases, you are supposed to give what is called as rescue breaths. So for adults, one breath every 5 to 6 seconds, that is a rate of about 10 to 12 breaths per minute. And if it is a child, then to match their physiology, one breath every 3 to 5 seconds in children and infants. Infants, naturally, the rate is more compared to children because infant is less than 1 year. Activate the emergency response system if you have not done before. If the person is not having breathing as well as no pulse, then you start the cycles of chest compression. So chest compression is essentially doing the work of heart, and 30 compressions followed by 2 breaths. This is what you must do. You wait for the AED which you have called in the help, and as soon as the AED comes, you have to use it. So we have already seen why the CAB sequence. Just little more points about the high quality chest compressions. So you can see in the picture that this is the place, the intermammary line where it crosses the sternum. That lower half of the sternum is the place where you have to give the chest compressions. So it is not on the left side, it is not on the right side, it is in the center of the chest, lower half of the sternum. You can see the posture. This person is kneeling beside the victim. He has his elbows extended and he is using whole of his weight to give the chest compression. So this is the correct position of giving the chest compression. So it is a critical concept, what is called as high quality chest compressions. So it consists of, first of all, to start the compressions within 10 seconds, because all of you know that heart, once it starts in infancy, it only stops when we are dead. So if you don't start that much time there is no perfusion going to the brain. So start the compressions within 10 seconds as early as possible. Push hard and push fast. What should be the rate? 100 to 120 per minute. If you don't push hard, you will not be able to create an effective systole for the brain and the vital organs to have perfusion. What should be the depth of compressions? It should be at least 5 centimeters for the adults, and in children and infant, at least 1/3 of the epidiameter of the chest, or about 4 centimeters. Next is you allow the complete chest recoil. So what is this chest recoil? The chest recoil is nothing but the diastole of the heart. When you do the compressions, you are going to give the forward flow. And when you are allowing the chest recoil, it is the filling of the heart. So the heart is ready for the next compression. Minimize the interruptions less than 10 seconds. Because as you all know, you are doing the interruptions, that much is the blood supply less for the vital organs. So CPR gives the critical perfusion to vital organs. Give effective breaths. I need not emphasize more on the breaths because all of you know what is our normal breath holding time. For adults, when we give anesthesia fitness, maximum is 45 seconds ASA1. So if somebody who's not having breaths or effective breaths, definitely it is not only the circulation, but it is the circulation of oxygenated blood, which is very, very important. So effective breaths are essential component of chest compressions and resuscitation. But you must avoid excessive ventilation. Why you must avoid excessive ventilation? Because excessive ventilation causes stomach expansion because you don't have a specialized equipment. So stomach will expand when you are giving mouth to mouth respiration. So it will be making the person to prone for the aspiration pneumonia. Also, it will cause a pressure on the diaphragm. And as you know that if the thorax also is affected, venous return is less. And if the CO2 is washed out, it gives rise to cerebral vasoconstriction, which is bad for such patient where the vital perfusion to the brain is already affected. So these are enough reasons to avoid excessive ventilation. Because you must have seen that when you are in hurry, you must have seen the JRs ventilating. They will do push, 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 push very fast because when it is a cardiac arrest, they also panic. So you have to try and avoid such conditions. There is a concept called as compression fraction. So it should be at least 60%. What is it? It is the proportion of time during the resuscitation that you are giving the chest compressions. And you are supposed to achieve about 80%. If you have a good team, you can achieve about compression fraction of 80%. So for lay persons, or say in a pandemic like COVID, where people are not ready to give breaths because they are afraid of catching the infection themselves. So we can teach the lay persons compression only cardiac life support. So that is called as COS. So without anything, if you are just giving the chest compression correctly, it will still give a perfusion to the vital blood supply to the brain. So people are encouraged and taught COS. Coming to opening the airway. So how do you open the airway? See, you can see that in unconscious patient, the tongue falls back and the airway is blocked. So merely by doing the head tilt and chin lift, you can see that the airway patency is restored. So when you want to give effective breaths, step 1 is to open the airway, make the airway patent, and then you will be able to give the breath. If you do not have the person who's using this pocket mask, which is actually a useful thing because it has a unidirectional valve, so he doesn't come in contact with the person's respiratory secretions. If you don't have this, you can pinch the victim's nose, lock your lips to the victim's lip, and then blow into his chest. So what is the indication that your ventilation is adequate? If you see a visible chest rise, then you know that your ventilation given is adequate. What is the fractional inspired oxygen concentration in the expired air? This also was an interactive question actually. Normally we are breathing 20.8% oxygen in the atmospheric air, and expired air still contains about 16 to 17% of oxygen, which is good enough for survival. If you happen to be in the hospital, many of us may be, That's why I have put this slide. So this is actually with equipments. So you can see this resuscitator, she's using ambu bag. You can apply oxygen enrichment to this ambu bag. There is a unidirectional valve here. Now this is called as EC clamp technique. You can see that these 3 fingers are forming E. She has put the jaw thrust maneuver to keep the airway open, and this is the C seal so that there is no leak. So she can give ambu bag ventilation. So this is the correct technique. If you have more than one person, that is you have 2 people who know basic life support, then one person can take up the compression job and the other person can do the ventilation job. After 5 cycles, if this person is fatigued, they can interchange the roles, and this way a team effort will go on, which is much better than a single person's resuscitation. If you have in the hospital and you have put in an advanced airway, say for example, laryngeal mask airway or endotracheal tube. So if it is there, then 1 breath every 10 seconds or the rate required is only 10 breaths per minute. The advantage here is the person can give uninterrupted chest compressions. So just like normal physiology, the heart is not waiting for the respiration to wait. So similarly, if you have an advanced airway, that is the advantage in the resuscitation. Now coming to the most important thing, automated external defibrillator. So why it is so important and why have we called for help? It is observed that the commonest cause of death is acute coronary syndrome. And all of you know that the incidence of acute coronary syndrome is increasing, and younger people are getting affected by this. What is the cause of death in heart attack or so-called as acute coronary syndrome? It is not the big portion of the myocardium. It is the abnormal rhythm. It is the lethal rhythm, that is the ventricular fibrillation. So normally heart is doing systole, diastole, systole, diastole in a rhythmical manner. What happens in ventricular fibrillation is there is a chaotic contractions. So there is no forward flow. So this ventricular fibrillation, if during this fibrillation you give an electric shock to the heart, then if the heart muscles are salvageable or viable, then the normal sinus node takes over and this heart starts its normal job, that is the synchronized contractions and relaxation. So this is the most important specific treatment. That is why we are focusing on automated external defibrillator. The interval from collapse to defibrillation is one of the most important determinant of survival from sudden cardiac arrest with ventricular fibrillation. And ventricular fibrillation and pulseless ventricular tachycardia, these are the commonest rhythms which gives rise to sudden cardiac death in patients with MI. So my talk is focused on this automated external defibrillator. If you happen to be present in the critical care unit and if you have your own manual defibrillator, then such patients you should give shock as early as possible. So you do the rhythm check as early as possible and give the specific treatment. So here I have shown the picture of AED. This is a small portable AED. We have asked for this AED when we have called for help. Now what is this PAD? It is nothing but public access defibrillator. So these are the courses, because these AEDs are kept in most of the public places in developed countries. Say for example, swimming tank, an auditorium or public garden. So many of these airports you will see in India as well. So public should be knowing how to use these defibrillators so that the person gets the help in time. So as the AED arrives, which you have asked for, first of all, being an electronic machine, you have to put the power on. After that, you have to put the leads. So one lead will go into the right infraclavicular area and the other will go into the apical area. You should stop the chest compressions for the AED to analyze the rhythm. Once the AED analyzes, because if you are doing the chest compressions, then the artifacts will be taken as ventricular fibrillation. So once you pause and allow the machine to analyze, the verbal visual prompt will come. Visual means it flashes, and verbally it will tell that the rhythm is shockable, shock advised, or rhythm is not shockable, shock is not advised. So if the machine says that the rhythm is shockable, then you must clear the victim, because our bodies are conducting. So this person is telling that I am clear. Is everybody clear? So this person who was doing compression, he is clear, and making sure this person is giving the shock by pressing the shock button. So after the shock button is pressed, the body will contract. That is an indication that the victim has got an electric shock. After that, you have to resume the chest compressions without checking for its effectiveness. So we have seen the procedure. If the rhythm is non-shockable, then you have to resume the chest compressions for about 2 minutes, and after 2 minutes you can recheck whether the rhythm is shockable or not. So how long should you continue this? Till the advanced cardiac life support ambulance which you have called for takes over, or the person victim shows the signs of life or successful resuscitation. So that is the end point. So this is the 2020 guideline. Verify the scene safety, check responsiveness, shout for help, or call for the AED, that is 108 for Pune. Then your action comes, that is 2 things, carotid and the respiration scanning. So both are there, monitor till the ambulance comes. If respiratory arrest, then manage the rescue breaths. If both are not there, cycles of 30 compressions, 2 breaths, and continue till the AED comes. Once AED comes, check whether it is shockable, and then go ahead and shock this. This is how you should go about. So this is the cycle of complete resuscitation. This is a new algorithm added in 2020, suspected opioid poisoning. This incidence is not much in India, so I am skipping these slides. So we come back to the scenario, and I would like to give a video answer because we have recorded a video in the skills lab. So you can see this. Ideally, actually, we need hands-on practice because this is a skill station. But because of the COVID, this being a webinar, I'm just showing you the video which is conducted in our own department. दूसरा आ गया. Play नहीं हो रहा? It is not playing. नहीं आ रहा. Can you?
Varsha madam, if it is saved on your laptop, you can show directly because otherwise the audio.
It is there on the laptop. Yeah, it is there on the laptop. Laptop मध्ये आहे. Because it's very important to show this. वो पहले बज रहा था जब हाँ वीडियो ये रहा ये ट्राई करो ये क्या हाँ I think so. नहीं हो रहा. Oh my God, so sorry. अभी मेरे को नहीं समझेगा. इसमें तो था नहीं ये नहीं. We cannot try like this. Already we are late. Madam, I think should we skip it? Should we skip it? देख लो try करके. Ah yes, we got it. Is it visible?
No, not yet, ma'am.
Okay, we got it. We got the video.
Yeah.
We got the video in the laptop. Yeah. This is the one?
No, madam. We can't see.
ये है ना? नहीं आया?
नहीं.
आ रहा है क्या? डाउनलोड इधर है. हाँ, this is the one.
We need to share the screen.
Because the video is very important. It is showing how to do it, because it is a complete summary of the.
Let me help you with that. If you have the video open, just come back to the Zoom window. And click on the green share screen button at the bottom.
दिखाई नहीं रहा है. तुम्हें अभी दिखाई तो दे रहा था.
Yeah.
हाँ, हमें दिख रहा है. What will you do? Can you see?
Yes, I can.
Yes.
You have to enter. Hey, are you all right?
No response.
You get an ambulance, call 108 and ask them to get an AED.
Is he audible?
I'm checking for the pulse.
No, ma'am.
He's checking the pulse. He has asked for help. Check the response.
Starting chest compressions. 1,
Look at the
2,
chest compressions.
3, 4, 5, 6,
7,
7,
8,
8,
9,
9,
10,
10,
11,
11,
12,
12,
13,
13,
14,
14,
15,
15,
16,
16,
17,
17,
18,
18,
19, 20,
19,
21,
20,
22,
21,
23,
22,
24,
23,
25,
24,
26,
25, 26,
27,
27,
28,
28,
29,
29,
30.
30.
So after 30 compressions, he's giving 2 breaths, mouth to mouth, pinch the nose. You can see the visible chest rise. He's again starting the chest compressions.
3, 4, 5, 6,
7,
7,
8, 9, 10, 11, 12, 13, 14, 15, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Again 2 breaths given. He will continue till he gets the AED.
2, 3, 4,
Next video is ready.
10, 11, 12, 13, 14, 15.
So once the AED comes,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
once the AED comes, he is going to connect the AED.
25, 26, 27, 28, 29, 30.
नहीं मिल रहा है ना, ठीक है ना, छोड़ दो मुझे, मेरे को और कुछ बोलना नहीं है। इस पे ले लो अभी जो चल रहा है। So once the AED comes, he is going to shock, right? So I hope that I am clear, because he has shown the good chest compressions, high quality chest compressions. It is your chest compressions which are going to matter for the successful resuscitation. मेरा नहीं दिख रहा है इसमें. So next condition which I would like to just touch about is drowning. Anybody has any special thoughts on drowning? Though the algorithm is shown, this is the 3rd leading cause of injury death worldwide. So here the sequence is little bit changed because it is a asphyxial condition. Here the breathing is affected. So you have to make sure that scene safety is there, because if you yourself don't know the swimming, you can't go and help somebody who's drowning. So call for help, your own scene safety. After that, you check whether the person is breathing. Here we are not going for circulation first. So CAB sequence is changed here. That's why I took this condition, and it is important to know. Many people, they try to clear the airway of the aspirated water. So you have to not do that. You have to not use the abdominal thrust also to remove water, because these are the mismanagements which are commonly done. You have to check the pulse after the effective breaths. And you all know that what is effective breath is nothing but when there is a visible chest rise. Next condition, as a dermatologist, you will be interested is the anaphylaxis. Everybody knows that it is a severe allergic reaction which requires urgent treatment. Here the prompt recognition is very, very critical. Common allergies involved are medicines, latex, foods, and the stinging insects. Skin changes alone is not a sign of anaphylaxis. You need involvement of 2 systems for the diagnosis of anaphylaxis. An immediate injection of epinephrine. You are not going there for the checking of responsiveness and all those things, BLS, which is described. Here, it is your clinical diagnosis which is very important. Once you know and suspect that it is a anaphylactic reaction, it is observed that use of epinephrine is very much underplayed. So immediate injection of epinephrine is the thing which is of most use. Coming to children, I am just going to quote you the specific points which all of us must remember. So children is from infant, from 1 year to puberty. Infant is little special. So in children resuscitation, you have to remember that if you are having 2 resuscitators, the compression to ventilation ratio is not 30:2, but it is 15:2, because to match the physiology, because they have more heart rate and more respiratory rate. So if you are 2 rescuers, remember 15:2. Compression depth, as I already told, is 1/3 the epidiameter of the chest. That much should be going down. Compression technique, for a say 3-year-old child, you need not use both the hands. You can do the chest compressions single-handedly. And depending on the size of the child, you can choose 2 hands. Then another difference is when to activate the emergency response system. So if you happen to witness the child collapsing in front of you, you can leave the child and go and activate the emergency response system. Whereas you come across or you have not witnessed and the child is unresponsive, then you first give 5 cycles or 2 minutes of chest compression and then go and activate the emergency response system. The reason being, in children, it is not the acute coronary syndrome which causes the cardiac arrest, but it is the shock and the respiratory conditions which give rise to cardiac arrest. So accordingly, this change is there in American Heart Association management of child-related cardiac arrest. Here I am showing the picture of one-handed chest compressions, a nurse doing that. Then for infants, it is another special thing. Location of the chest pulse check, you can check actually the brachial artery instead of the carotid artery. The technique of compressions, if you are 2 rescuers, then it is 2 thumb encircling the hands technique. And if it is a single rescuer, then you can use it with the 2 thumbs. So you can see in the picture, see this is 2 finger technique and this is the 2 thumb encircling the chest technique. So these are the 2. This is far superior. So if you have 2 resuscitator, you can use this technique and it gives rise to a very good quality chest compressions. So these are few differences. Depth I have already told. Ventilation and compression ratio. If 2 resuscitators, then 15:2. And as I have already told, when to call the emergency response system. So this was additional thing is, if despite oxygenation and ventilation, the pulse rate still remains 60, less than 60, and if the child is showing signs of poor perfusion, you can start the CPR, that is cardiopulmonary resuscitation. So this is special thing for infants and children. Use of AED for infants and children. If you have a manual defibrillator, then it is preferred to AED because AED will give the full dose. If it is not, then if you have a AED with pediatric dose attenuator, there are some AEDs. If you have a specially pediatric hospital, then you can choose this with a pediatric dose attenuator, then it is preferred. But if it is not there, you can still go ahead and use the standard AED. Initially 2 joules per kg energy can be chosen. And as in adults, after the shock, you have to resume the chest compressions. If it is unsuccessful, you can double the dose of energy, but maximum dose is 10 joules per kilogram or the adult dose. Other important thing is choking, which is a very important cause of cardiac arrest, and you can come across any place. So this person is showing universal choking sign. So he is not able to talk. So he is showing by putting these hands like this that there is a choking occurring. So we will only talk about the severe airway obstruction because in mild cases the person will be still able to speak, in which cases he is encouraged to cough out. But in severe, if there is no poor exchange, very ineffective or weak cough, there is high pitched noise which is coming, and there is increasing respiratory difficulty, you should call the ambulance, right? You should encourage the person to speak. And there is something called as hemorrhage maneuver. So this hemorrhage, he was a person who recently died at the age of around 100, and he revived many people like this. So you can see that the person has made a fist, and you have to put this fist between the zipisternum and umbilicus, and you have to give upward thrust so that the foreign body will come out. So if such in infants, this is the technique, back thrust and the chest thrust, back slaps and chest thrust. This is the technique. So if such person arrests, then you have to start the chest compressions breathing. One step is extra here. Every time you open the airway for giving breaths, you should carefully look for any foreign object which is obstructing, and you should try to remove. But you must avoid blind finger sweeps because it will dislodge and make the foreign body to go inside much deeper. Effective team dynamics, this is all essentially related to basic life support happening in the hospital. So I'm not going ahead with all those things. I hope I'm clear about it. If anybody has any questions, anybody has any questions? म्हणजे मला दिसेल तो chat box. I don't think
Is Dr. Good evening, Dr. Varsha. Kalash, Dr. Suhas is also here.
Yeah, so if he has something, I have kept some time. I think I try to finish it faster.
I have one question. During
Yes, please.
COVID times, are there any changes?
Yes, so I have one slide actually. I had kept it ready because I expected this question. So there is one slide. Question के बाद में है. हाँ. So this is the protocol. This is the American Heart Association protocol. नहीं, इसके पहले है. हाँ. So this is, you can see this signal. So use of PPE. So
Okay.
they encourage the use of full PPE because cardiopulmonary resuscitation is an aerosol generating procedure. So you are supposed to wear, but wearing of PPE will hamper the resuscitation because you all know that time is of essence. So one of the person should start the resuscitation, at least hands only chest compressions, till the other person is getting done with the PPEs. And this sign you can see, this is HEPA, that is high efficiency particulate air filter. So you have to use the HEPA filter. It filters the virus about 99.9%. So these are the two extra things. Otherwise, the recent guidelines there is not much change. This is in regard to the COVID pandemic which is going on. It's a very good question, and I hope I am clear.
Yeah. Dr. Suhas, does he wish to add something in this presentation? He can start his video actually. We cannot see him. Okay, ideally,
I'm thankful to all of you for your patient listening, and I'm very grateful for IMA Pune for inviting me for delivering this lecture. Thank you so much.
yes. No, this was an excellent presentation, but I hope that these COVID times are done and we can have a direct, live demonstration.
Hands-on is
That
very
is
important.
more needed so that we can have the physical activity.
Varsha, very nice. I'm here only.
Yeah, thank you so much. Thank you so much.
So we are really grateful, and Dr. Deshmukh sir would like to felicitate you. Sir,
I thank all the faculties, Dr. Pradyumna Vaidya, Sunil Tolat sir, Dhanashiri Bhide, Mankar sir, and Varsha Shinde madam. This was very nice presentation from all of you, and our secretary Sunil Ingre and Alka madam had taken, and this Geeta Anjali has taken a lot of pains to make this webinar very successful. I thank you all. And madam, this is bouquet for you.
Yeah, thank you, sir. I can accept it virtually.
And one Uparna, IMA Uparna for you.
Thank you so much.
IMA Pune also would like to thank all the delegates who joined today. It was an excellent session. There were many questions, and I'm sure many of you have still more queries. We would try to give you the YouTube link of this session. So those who are interested can write to us and we can share the YouTube link, those who are interested. We would also like to thank Dr. Sanjay sir for being the observer for today for MMC. And this is the second session in the series of 4 sessions by IMA Pune. So tomorrow there will be another CME, and I request all of you to join again for tomorrow at 2 o'clock.
Thank you so much.
So, thank you very much to all the speakers, all the faculty. Thank you, Sanjay sir.
Thank you, all the faculties. Thank you, President sir. And thank you, Geeta Anjali madam, all the delegates. Thanks a lot. Excellent academic session.
Thank you.
I was hearing from the very start till end.
Yes,
The
sir.
best of all. Thank you. Good day.
Good day. Thank you.
Finish?
Yes.
The quality of faculty is very nice.
Nice. That is the important thing. प्रद्युम्न काय मानकर काय लोक धनश्री काय कलेक्शन आहे ना Correct? त्यांची स्वतःची असं कुठून तरी घ्यायचं